Good afternoon, everybody. It is great to be organizing this session for Kerala. We had all the doyens of adults in medicine. Great program that has been Please mute everybody. Hello. Yeah.
Yes, sir.
Anyway, we got the doyens of adults in medicine here for this program, and I congratulate Deepa for doing this wonderful program for us. She's done a lot of work, and we have got these. Some changes are there. I think Dr. Paul Russell couldn't come because he's got some problems, and instead we got another doyen, Vivek Benegal, to do the substance abuse one. He's done a lot of work there. And we've had a lot of good programs from Bansal, Dr. Bansal, Dr. Swati, Dr. MKC, Dr. Shekhar Sheshadri, and Preeti, and all the doyens of adults medicine for this program. I'm sure all of you will enjoy it. I hope all the adults medicine people are there and all the PGs are in tow. They're going to have a great time. I wish everybody all the best. Thank you so much.
जो ठंडी है वो देना भैया जी.
I invite Dr. Swasant Kalatkar, our President IAP, and the AHA President, Chairperson Dr. Himabindu Singh for this program. It's great to have you both here for this wonderful session. Thank you. I also invite all the speakers and all those who are attending. AHA Kerala has done a great job with Dr. Ranjit, Dr. Shibu, Dr. Deepa, and all have done a great job as far as North AHA in Kerala is concerned. Geeta Patel did a great job last year as the chairperson of the AHA national level. So we got all of them here for this program. Kamath Sachi is there. So we have a great team. I hope you all have a great time. Thank you so much.
Thank you, sir. Now may I invite the vibrant chairperson of AHA Kerala, Dr. Deepa Janardhanan ma'am, for the presidential address.
Good afternoon, one and all. Respected Dr. Vasant Kalatkar, Honorable President, Central IAP, Dr. Himabindu Singh, Honorable Chairperson, Central AHA, Dr. Riyaz, Honorable President, IAP Kerala, Dr. Vivin, Honorable President, IAP Cochin, all the esteemed speakers, chairpersons, and other dignitaries here, and my dear friends. Earlier this year, in January, in my own hometown, Cochin, Kerala, we lost two adolescent boys. They both killed themselves by suicide. One of my colleagues happened to live in an apartment where one of these boys lived. Weeks after the event, she was telling me, Deepa, I'm scared to leave my kids in the apartment. I keep calling them. I keep the locks shut. Such is the effect of a suicide on the society. This happened in January. Next month, in February, in Kozhikode, another district in Kerala, a 15-year-old boy was murdered by his friends. It was a big news. The media, the TV channels kept on discussing on it. They came up with various reasons for the lower threshold of violence among teenagers. They blamed the media violence, social media, the gaming disorder, everything. The next month, March, we saw the release of that web series Adolescence, which most of you must have watched, that depicted the murder of a 12-year-old girl by her classmate. When we went into the intricacies of this murder, it revealed the various dimensions of the virtual life of the present-day teenager, which we, the millennials or the Gen X, we, the pediatricians or the parents or the teachers, are quite unaware of. So with this background, we, the office bearers of AHA Kerala, IAP Kerala, and IAP Cochin, decided to go ahead with the second season of Minds of the Future, the first of which we had in 2021 amidst COVID, and that was a grand success. So today, this moment, which I call as a blessed one, where we have all the doyens in adolescent pediatrics, not just across the country, but even abroad, which you all are longing for. And I don't want to waste your time. Let's move on with Minds of the Future, Season 2. Thank you.
Thank you, ma'am. Now, to invite our chief guest, may I call upon Dr. Ranjit P., Joint Secretary of IAP Kerala, and immediate past chairperson of AHA Kerala.
Good evening, respected Chairperson of AHA Kerala, Dr. Deepa Janardhan ma'am, respected National Chairperson of AHA, Dr. Himamidhu ma'am, respected teachers, MKC sir, Saudi Baba ma'am, and all the dignitaries. It's my proud and privilege to introduce our National President of IAP, Dr. Vasant Kalakar sir. Sir is a simple and dedicated pediatrician from Nagpur. He is the National President of IAP 2025. Sir has the recipient of BC Raw National Award for the medical field and also received so many awards, the Dhanvantari Awards, and Sir is a fellow of Indian Academy of Pediatrics from 2010, and Sir was the organizing chairperson of the prestigious Pedicon 2018 at Nagpur, and he is a great leader, and his community-oriented program, Bye Bye Anemia and IAP के बाद community के साथ program going so nicely all over the our India. So with these few words, I invite our uh, National President to Dr. Vasant Kalakar sir to inaugurate the function.
Good evening, all, and happy Sunday. Respected Dr. MKC Nair, Dr. Sachidanand Kamath, Dr. CP Bansal sir, Dr. Deepa Janardhan, Dr. Jesus Unni, and all Dr. Hima Bindu, chairperson of AHA chapter, who is doing really excellent work, excellent ideas, and excellent sessions. Uh, she don't like it's like a adolescent. She is behaving like adolescent that she never stops. That's really great, Hima. And I really want to congratulate and wish you all the best for your future prospects. So, and all my delegates, my young friends, and all my today's faculty from overseas. It's really great achievement and great event is going on. That is the second session. Thank you, Deepa, for after me that I couldn't resist myself to come for this program, though I was in traveling. See, I know the adolescence is like a phase. When sometimes it is silent, sometimes it terminates. Wherever today I went for a CME, there was a jungle was near, and I sighted a tiger in that jungle, and he was sitting for 15 minutes. So we were silently observing. Then he started walking slowly. Then he became aggressive and he had done hunting. Is it he has done whatsoever he want. So that's a, like a, I was comparing adolescents really. That's like a that. That's a they are really tiger and they are behaving like that. Whatsoever they want, they are doing. But sometime, whenever there is a hunting, we lose something. Though it's a food for tiger, but we lost something. But like it's like that. Sometimes in adolescence phase, I'm not master. I know this is not my cup of tea. Like when Dr. Bansali is there, Dr. M.K. Nair and Hema is there, I should not say. So this, they need a direction, and that's we are doing. That's a great job AHA chapter is doing. And that's really one of the best chapter we are having. So about the mental health, there are so many diets in adolescents. They will talk about more. I should not talk about. And really, it's a great job. Great is going on. Thank you, our international faculty, those really joining and having a collaboration with India. Thank you, Ranjit, for my brief introduction. So, and all the members of Adolescent Chapter, wish you all the best. Sir. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Now, To introduce our guest of honor, may I call upon Dr. Ranjit P., Joint Secretary, IAP Kerala.
Good evening. It's our privilege to have our National AHA Chairperson, our respected Dr. Himbindu Ma'am, as our guest of honor. Madam is the Professor of Neonatology and Pediatrics, Osmania Medical College, Hyderabad. Madam is the Dean RGMC, Government of Telangana. Madam was behind so many wonderful modules that AHA, Central AHA released this year. That adolescent boy module, which was released just few days back. And also, Madam is behind us, the UA CMEs and all. And she is always promoting the youngsters and also fellow colleagues. And over to you, ma'am, for your address.
Thank you, Dr. Ranjit. First of all, respected Dr. M.K. Nair, sir, Dr. Swati Bhave, madam, Dr. C.P. Bansal, sir, our own Central IAP President, Dr. Vasant Kalatkar, sir, and many dignitaries, Dr. Kamath, sir, Dr. Geeta Patil, and my colleagues all over from AHA. I would really congratulate the organizers, Dr. Jisa Nuni, Dr. Deepa, Dr. Vidhu, Dr. Swati, and from, supported by Dr. IAP Kerala, Dr. Riaz, Dr. Gopi Mohan, Dr. Binu Kitan, and from IAP Cochin is also supporting AHA activities. Vibin, Dr. Bhay, and Dr. Ramya. I really congratulate all of you for organizing this wonderful CME, which is international, where we have doyens of adolescent health experts from India and few from abroad. And this effort of conducting on a virtual mode for so many hours, this shows a testimony in how IAP Kerala and AHA Kerala are always in the forefront. And you are hats off to you, salutations to all of you that you're organizing this program. And Deepa and all the organizers, I'm so happy that Kerala is always on the forefront in adolescent health activities and all activities, I should say. And I thank our IAP leadership, Vasanji, for supporting Adolescent Health Academy in all its activities. Recently, we have signed a declaration called Hyderabad Declaration, which is advocating for celebrating one day in a month, that is 18th of every month as Youth Wellness Day. Yes, this year we are doing a lot of celebrations, like Dr. M.K. Sinai said, everywhere there's adolescents and adolescents and adolescents. So we are doing, I think we owe it, and we are celebrating adolescent health issues for throughout the year with a lot of innovative activities this year. Our committees and support from OB, EB this year is so excellent that we have came many innovative programs like involving young people in all our programs. The youth voice is being heard, and youth-led activities are happening. We have the child module, we have the module going to come in. We have the ULS module, which is going to cascade all over the country. So we have a lot of things have this innovations happening, and branches and doing excellent activities. I invite you to National Adult Squad at Ahmedabad too, and really celebrate working on mental health. Yes, I think we are the only chapter who's working for the community to a large extent. All are members passionate, and what AHA is today is because of the stalwarts, the dog made what. We're just adding on to it. I hope we continue this legacy forward, and through all that work. Oh,
Yes, ma'am.
yeah. So and it's my pleasure to with all of you. Thank you. Kudos to all of you.
Thank you, ma'am, for the encouraging words. Is there any technical issue? Or I think
We continue,
yeah,
Shweta.
it's okay. You. Yeah, please go ahead. The best for the today's.
Thank you, ma'am, for the encouraging words. Now, addressed by IAP President President of IAP Kerala was planned. However, due to unforeseen circumstances, Dr. Riaz sir have not yet joined. So in his absence, may I request Dr. Gopi Mohan sir, Secretary IAP Kerala, to address the gathering.
Shweta, we can continue. We can continue directly to the proceedings. No need to extend it. Hello?
Oh, okay, sir. Okay, sir. So moving on to the felicitations, may I invite Dr. Vivian Abraham, the vibrant president of IAP Cochin, for the felicitations.
Good evening, everybody. Respected CIP President Dr. Vasant Kalkar sir, AHA President Dr. Himabindu, Dr. Jason Siunni, Dr. Deepa, Dr. Riaz, Dr. Gopi Mohan, MKC sir, Sachi sir, and all dignitaries. It is my pleasure to get associated with the national level IAP and also with the AHA chapter for conducting this important adolescent meeting. And as Dr. Deepa has already mentioned, we had a few cases of suicides in the adolescent period where we had a few counseling sessions for the teachers because they were in need of those. So I think it's a right decision in the right path to create awareness about the new issues which we have to face and also be prepared for dealing with these issues. So I wish all the program the very success. Thank you.
Thank you, sir. Now may I invite Dr. Shibu K. sir, South Zone EB member, Central AHA, for the felicitations.
Thank you, Dr. Shweta. Respected dignitaries on the platform, very good evening to all. I would like to congratulate AHA Kerala for conducting an international CME on adolescent mental health with most eminent speakers. And I would like to thank IAP Cochin team for organizing this fantastic program. I wish all the best for the program. Thank you. JAAP, JAHA.
Thank you, sir. Now may I invite Dr. Vidhu Ashok, Secretary, AHA Kerala, to deliver the vote of thanks.
Thank you. Good evening, all. Happy to see our respected guests, organizers, and participants for our academic feast. On behalf of the organizing committee, I would like to thank IAP Kerala, Central AHA, and IAP Kochi for all the support. We extend our heartfelt thanks to Dr. Vasant Kalkar sir, President CIAP, for inaugurating our program. And also we are grateful to our own Central AHA chairperson, Himabindu ma'am, for madam's words of encouragement. Our special thanks to President IAP Kerala and Secretary Riaz sir and also Gopi Mohan sir for the continuous support, and also IAP Kochi Dr. Vivian and also Dr. Abhay for the continuous support. And our organizing chairperson, Dr. Jason sir, special thanks to you, sir. You have made all the impossible hurdles possible for us. And our special thanks to our AHA chairperson, Dr. Deepa Janardhanan, who has been working over it for a month and made it possible today. And always a backbone and helped us a lot as our past immediate chairperson, Dr. Renchit, and also Shibu sir for the continuous support. Now, for unfolding our beautiful program, we have a lot of stalwarts with us, and all of us, I do not want to waste time, but a special thanks from AHA and all of us to all our speakers and chairperson, Dr. C.P. Bansal sir, Dr. Kamath sir, Dr. Preeti madam, Shaji sir, Dr. Vivek Bengal sir, Dr. Atul Kanitkar sir, Dr. Swati Bhave madam, Himabindu madam, Dr. Shekhar Sheshadri sir, Jisununi sir, MKC Nair sir, Geeta Patel madam, Newton sir, Dr. Shamit Ghosh sir, Dr. Michael Rich, who has crossed the zones and is being in our meeting today. Thank you, sir. And also Dr. Sushma Desai. Time is limiting, hence our thanks is just extending for all of us. And special thanks to our MOC today, that is Shweta, and all the participants. Great feast to all of you. Thank you.
Thank you, ma'am. With this, we come to the end of the inaugural session. Now we move on to the exciting scientific session on adolescent mental health. Over the next few hours, we'll be discussing various aspects of adolescent mental health, from identifying signs of suicide to addressing peer pressure and reckless activities. So let's get started. We have a fantastic lineup of speakers, and I'm sure everyone will find the presentations informative and thought-provoking. Our first session is on understanding adolescent mental health, identifying early signs of suicide and self-harm. The chair for this session is our respected Dr. S. Sachidananda Kamath sir, who does not need any introduction among pediatric fraternity. A renowned pediatrician working in Indira Gandhi Hospital, Kochi, past national president of IAP. May I invite you, sir, to chair this session and introduce the speaker. Thank you.
Thank you, Dr. Sweta. Respected President, National IAP President, Dr. Vasant Kalakar, President of the today's AHA Kerala State, Dr. Deepa, other dignitaries, faculty members, other members, senior colleagues, past presidents, my dear friends. It's a great honor to be here today, to be the chair of the first session, that too for my close friend, Dr. C.P. Bensal. And I should first congratulate the organizing team, especially Dr. Deepa, which I know that to organize a whatever the event, that whichever the way, it is a smaller state level, national level, or whatever the method you are, to get the speakers, to get the going in the on time and get the subject of the current issues, and of course the faculty as well as the international faculty. It's not an easy job, and Dr. Deepa and her team has been working for the last 1 or 2 months, which I also have been a part of it, which she had been reminding me even in this morning also, to get started on the today's meeting on time. So really congratulate the team, Deepa, and the Kerala State and the IAP Cochin branch, and the initiative taken by AHA Central Office, that is the Dr. Hima Bindu, who had been helping for all the activities of the AHA for the last so many years, but this year as a chairman has been helping. It's also very good. And to come to the point, today's subject, first initial, that's the opening subject, which is a very important subject, that is the identifying the early signs of the suicide and the self-harm. That is the very current to that, and as the Dr. Deepa has mentioned, we have gone through that in Cochin, and after the first episode of Cochin, that we met with the principals of the, and Dr. Vivin, myself with others also, Deepa and others, were planning, we planned the regular classes in the school. So that was a kickstart for a real eye-opening for the Cochin to do a lot of activities for a repeated things, other than the drug abuse and other things which has been going on for this so many last 2-3 years. You all know that suicide and other topics, which I don't have to mention, where the subject has been taken care by the faculty like Dr. M.K. Sinha, Dr. Swati Bhave, Dr. Digita Patel. All these speakers are doyens in the C.P. Bensal. All are doyens in the adolescent field, and none can expect more than this from this today's mental health CME. And to introduce Dr. C.P., it will be a superfluous to introduce Dr. C.P. Bensal, called as C.P. By his mentors and by his followers, who all are C.P. sir or C.P. Has been mentioned for the last 38 years in pediatrics, and almost all the years I've been working in the IAP in the various capacities also, as from the local branch to the national level, as the Golden Jubilee President, a rare opportunity cannot get to every pediatricians of the country, which has been a memorable year where the projects which has been initiated by then President Dr. C.P. Bensal, like the Mission Uday, Mission Kishore Uday, and various other projects which has been going on for the so many years, like 7-10 years, and still it has been remodified and has been looking into that. and he has been the national level in the AHA as well as other forums also. He was the first founder president of the SAPA, which has been a rare opportunity to get that opportunity. Then orations he have been given, that M.K. Sinha orations or Dr. Swati Bhave oration, various orations, about 7, 8 orations he has begun. Nothing special to tell him about more than that. It's a close friend of mine, and he has been working for principles and to talk in any forum about the principles which he kept it on there. And for him, as an organization, he takes the organization first and then only the individuals or anything which comes in any way. And he fight for it, he execute it, and he makes sure that it has been implemented also. Such a great man, which I have the opportunity to introduce. Thank you. Over to you, CP, my close friend, dear CP, to you for the opening session of today's International CME on adolescence. CP.
Thank you so much, Sachi, for such lovely words. I'm really humbled. Thank you so much. Good evening, everyone. To be speaking with so many luminaries is really an emotional moment for me. It is really a deep privilege to be a part of this international CME on adolescence being organized by IAP Kerala, AHA Kerala, and IAP Cochin on very important topic fostering safety and preventing self-harm and violence in adolescents. Friends, in presence of stalwarts like my own teacher and guide, respected Professor MKC sir, and our mentor and a tireless crusader of adolescent health, respected Madam Swati Bhave, it is really very humbling and heartening for me to speak. It's really an honor for me today. I also extend my respectful gratitude to President Indian Academy of Pediatrics, Dr. Vasant. Your address really adds stature to this event. Dr. Hima Bindu, the President, current President AHA, and a force behind all the activities of AHA currently. Dr. Shekhar Sheshadri, Dr. Preeti Galagali, and Dr. Newton Lewis, whose international perspective strengthen our understanding of adolescent risk behavior in this digital era. What to say about my lovely Dr. Kamath, vibrant IAP leader, past IAP president. I am really honored that he is chairing my session with his charismatic insight. Dr. G. Sanunni, whose academic legacy continues to inspire generations. Dr. Deepa, if you take one name behind this entire international CME, it will be Deepa, and rightly said by Sachi. Dr. Shaji, Dr. Atul Kanikar, Dr. Geeta Patil Madam, Dr. Sushma Desai Madam, Dr. Shamik Ghosh, and all leaders of adolescent health, Dr. Riaz, Dr. Vimin Abraham, Dr. Shibu, Dr. Vidhi Ashok, Dr. Shweta, the gracious master of ceremony today. A special thanks to all of you and all the past and present chairperson of AHA, leaders of AHA, IAPians of Kerala, and passionate pediatricians, colleagues, and lifelong learners who are with us today. Friends, it is really very interesting to see that every adolescent suicide, there is a silent whisper that often go unheard. Today, we will try to learn how to hear them before it's too late. Having worked in adolescent health for decades, I know that recognizing these silent signs and cries is never easy, but it's something we really need to master. So Let us join our hearts and hands to build safer emotional spaces for our adolescent. The session will focus on understanding adolescent mental health and identifying early signs of suicide and self-harm so we can intervene before the tragedy strikes. It is a collective call for action to listen, to observe, and to intervene. With this initial remark, let me have the permission to share my screen. May I? Is it visible?
Not yet,
Sir, not yet.
Now?
Yes, sir.
Now it
Yes,
is
sir.
visible, sir. Yeah.
Thank you so much. So, friends, under identifying early signs of suicide and self-harm is really very important and is need of the hour. Let me begin with this finding of National Crime Report Bureau in 2022 saying that there was an increase of 10% in suicide while the increase of student suicide was 21.2%, almost double. So that simple point highlights, and this study is by Government of India's department, which we all know is grossly underreporting. So let us see the suicide landscape, and this highlights the early intervention because the trend is worrying. So this is the trend, and I want to highlight that in last one decade there is almost 4.5 to 5% increase every year in student suicide. So much so in last 10 years it has increased to about 57%, and it accounts for the third leading cause of death in students after infections and road accidents, while globally it is the second leading cause after accidents. And the total global suicide of a student is 1,12,000. So we account for almost 12% of global student suicide just in one country that belongs to me and you, with gross underreporting. One student suicide is there per hour. Actually, it is 28 per day. And we know that after every committed suicide, there are 20 suicide attempts. So it is urgent need for action is there. We are in Kerala and these are the hot spots, Kozhikode, and rightly been said by Dr. Deepa that why this CME. And I salute you guys for focusing on the topic before it becomes huge. You started working on neonatal mortality rate and you reduced it to single digit, setting an example for the country. You are not even in first 5 states with students suicide high rates. Still, you are focusing on this youth suicide today. So this clearly speaks volumes about your dedication, and I really congratulate the entire team of Kerala under the vibrant leadership of our mentor, Dr. MKC sir. Each year, after every result declaration, there are reports of student suicides. Again, congratulations. Kerala is a state which has state youth commission, and you have studied teen suicides, and you found that relationship, academic stress, and mental distress are the leading causes. Not only this, hanging remains the predominant method of committing suicide. The second landscape is from suicide capital of India. We all know the hub of preparation of for competitive examinations in India, Kota. Friends, we have 4,000 cities in India and we have 13,000 student societies. So nearly for each city, it comes out to be 3.5 or 4 maximum. What if one city, and that too a small city, account for almost 26 suicides in a year? You will definitely call it as a suicide capital of country. This is the graph every year, barring apart when students were not there in during COVID. Every year the suicides are there. It was 26 in 2023. It came down to 17 in 24. And in May, it is almost already 14 crossed, which is not even half year is gone, but 14 suicides have already been reported from Kota. Thanks now that we have a ruling in Kota that every hostel, we have almost 20,000 hostels in Kerala and 40,000 paying guests, that ceiling fans now have a anti-suicide ceiling fan, which in place of a rod have this spring. This was a wonderful study conducted over a period of 26 years, and they studied and analyzed the suicides from the data of National Crime Report Bureau, and they found that since last 26 years the suicide rate in a student is increasing, and they alarmingly found that it will continue to increase for next 10 years. Adolescent suicide is preventable. That is the reason why we are talking about it today. 50% of it is hidden crisis, because less than 50% of at-risk adolescents have ever identified or received any timely mental health intervention. So definitely it needs a lot of work to be done. Every suicide show many early warning signs, self-harm behaviors, and various other signs we will be discussing. So pediatricians should be the first responders, because we can assess those signs if we have a aim to look for them, because adolescents come to us for various reasons, for their illnesses and also for vaccinations. So this should be taken as an opportunity. Early recognition is our window to find out these signs. In India, where stigma is high and mental health services are limited, we may be the only line of defense. So our job is just not to diagnose, it's to listen, notice, and to act early. And we will see that why it is pediatricians that need to be paid maximum attention. What is the landscape of mental health status in adolescent? 1 in 5, that is almost 20% of our precious adolescent health, has diagnosable or detectable mental health disorder. And these disorders doubled during and after COVID-19. Many a times they are having vague physical symptoms like pain in abdomen, like headache, like fatigue, like weakness, and they mask the main mental health issues. So it is our duty to look deep into them and find out these mental health signals. I will start again with a case in Kerala. A 16-year-old student in Kerala was found dead after failing in board exams just 2024, last year only. It is a case of exam pressure suicide. This poor child has depicted so many signs of withdrawal from friends since last couple of weeks, had insomnia, and has been expressing hopelessness to his friends also. But nobody could realize the importance, not the parents in home. The teachers also could not find the gravity of the situation. When for insomnia and other things he was brought to healthcare services, they also ignored or could not pay the desirable attention to the underlying signs, and thus no psychiatric help could be sought for this poor child who finally committed suicide. Student suicides in India. This was again an early intervention psychiatry journal. It was published in 2025, and they have analyzed the suicide which were published in 4 leading national newspapers in a period of 5 years. And they found that academic reasons are there, they or institutional, the toxic environment, bullying, caste discrimination, ragging, harassment, either academic or institutional or both, might be coupled with mental health or financial crisis or online gaming. These were the basic reasons or the risk factors of suicide which this article, which was published in PubMed, found. Let us see the major risk factors for teen suicide in a little detail. Any one reason usually is not responsible for suicide. There is always a coupling or too many reasons piling up, and that leads to suicide. Like if an underlying mental disorder is there, anxiety or depression, this child has a history of prior suicidal attempts also, having some family contact conflicts in the family, and is having bullying or toxic environment in a school or in coaching, is most likely to go for this. If he is having some physical issue or physical disease or chronic pain, then it further adds to the chances. However, if this child is consuming some alcohol or edible substance or is addicted, then his impulse control is less, and therefore he is more liable to go for suicide. As is the importance of risk factors, similar is the importance of protective factors also. If a child is having strong emotional bonding in family, it could be even life-saving for the child. If he is having a good cohesive atmosphere, encouraging atmosphere in school, good teachers, good peers, and positive relationships in school, then it is a great thing. And if he is having a poor atmosphere in a school but a very good strong emotional bound family support, then it can act as a cushion, and vice versa also. In a school there should be good coping skills taught to the child, which brings him resilience so he can absorb the stress in a much better way. School connectedness is also very important. And if all of these are there, then timely access to mental health services becomes very important. If the mental health intervention is done timely, we have seen that suicides, they are usually, certainly preventable. Let us see various behavioral warning signs. Of course, they are subtle and usually they are missed. Hence, our mind should be acutely looking for them. If a very charming and active child, usually going for all the trips and taking part in school activities, withdraws from friends and withdraws from the activities, then it is an important sign. If his academic performance is decreased, then it definitely again adds to the risk factor. A very happy child suddenly starts showing mood changes, becomes irritable, agitated, and tolerance is decreased, then again it is another risk factor. So if various risk factors are there, they becomes the important warning signs. A child, even if in joking, talks about dying, that I am going to die, or there is no fun in living, and I am useless, nothing will happen if I die, then these talking should be considered as red flag and must be very seriously looked for, and referral should be arranged. Therefore, friends, I say that not all wounds are visible and not all cries are loud. Train your eyes and ears to pick up silent distress. Your stethoscope might not hear it, your eyes and heart might. So, definitely work accordingly. Let us see certain physical and verbal clues. Unexplained injuries or wearing concealing clothes. Summer may be, if a child is coming, adolescent is coming with hood, full sleeves, then look with the eye of suspicion. While examining, open the clothes and look for any injuries in the wrist if they are there. So it becomes a very important sign. If child expresses feelings of worthlessness, I am useless, nobody wants me, it would have been better if I would have not born. Such things are really important. If an student start giving his lovely belongings to others, look at this at a with a eye of suspicion. A child very active suddenly becomes calm, stops talking, and remains depressed, isolated. Do not talk to anyone, do not go out if a guest comes. Then again, this should be looked with a sign of stress. Let us see another case of cyberbullying and self harm. This 15-year-old girl engaged in repeated cutting after online harassment or bullying for months. Parent noticed long sleeves in hot weather, which were characteristic of this we have just said, but they couldn't pay any attention, considered it as normal teen behavior. Emotional isolation and declining grades were also there, but it could also not be uh, paid attention or looked at with gravity. Non-suicidal, this was a case of non-suicidal self-inflicted injuries like cutting, burning without intent to die. There was no intent to die in such cases. They are not attention seeking steps, remember, but they are used to cope with overwhelming emotions child is passing through. In fact, they are silent cries for help, silent cries for help. And in such children, empathy matters. And it is said that one empathetic, non-judgmental question can open the door to healing. And we must be empathetic with these children. Poor non-empathetic response, why are you doing this to yourself, will shut the child and close the door. But if you give good empathetic response saying that I noticed some mark on your arm, I want to understand what you are going through. Empathetic language build trust and encourage disclosure. Case 3, this is of successful early intervention. Same case, but here when this child was brought to the pediatrician for some complaint, pediatrician identified self-harm scars during routine checkup. He asked the child to remove that full sleeve sweater and note that immediate counseling and referral prevented the suicide attempt. Teen turned to the school with support network. So this similar empathetic response from the child for with the child saved the life of this child. So case 1 was of missed opportunity where pediatrician did not inquire about self-harm, continued self-injury, In case 2, we identified NSSI after 6 months when the suicide was attempted, and case 3, successful intervention by a pediatrician who promptly recognized NSSIC, the outcome improved. Let us see the screening tools for pediatrician. When a pediatrician do proper screening, he can immediately find the high risk behavior within 10-15 minutes. And these are the 3 tools: PHQ-9, in which the question 9 is important. Ask 4 questions and is path warm. This is PHQ-9, in which the ninth question is: thoughts that you would be better off dead or of hurting yourself in some way comes to your mind? Not at all, several days, more than half days, or never? If any of this is yes, it is a red flag sign. Arrange referral. Similarly, slides are visible. It's not able to move in my system.
Slides are visible, sir, but not moving.
Now moving.
Now it's moving, sir. It's moving.
Moving.
Now it's ask for. These are the list of 4 questions. If any of the, is it visible now?
Yes, sir. Yes, sir.
Yes, sir.
So if any of these question is yes, then again it is a red flag sign and arrange for the referral. Is path warm, like ideation, thoughts of suicide, substance misuse, purposelessness, anxiety, trapped, hopelessness, withdrawal, anger, recklessness, or mood changes? You can definitely identify the high risk. And if any of yes in ask 9, ask 4 or PHQ-9 is there, then definitely it is a high risk case. Even if by is path warm, the less is less, the risk is less. But if any of yes is there, then this child is definitely a red flag sign. Role of pediatrician: we must build trust and rapport. That is most important, by being empathetic and being not judgmental, showing acceptance to the student. Ask open-ended questions. Do not ask questions which need just yes or no. Let them speak and be a very active listener. Provide initial counseling, and if you feel that there is any red flag, arrange for referral and arrange for a specialized mental health intervention. Partner with the schools and mental health professionals. I say that even small steps by pediatricians, asking the right question, listening without judgment, can change the trajectory of young life. Brief intervention approach: as I said, listen without judgment. And the intervention approach, the mnemonic is rapid, recognize, observe the cues, screen for risk. If there is any risk, acknowledge it. Thank you very much that you have trust on me and you reveal this to me. I am happy. So never be always acceptive. Never show judgment. You are bad. Why you have done this? Acknowledge and empathize. Plan immediate safety. जितना भी remove lethal means, ऐसा atmosphere immediately बनवा दीजिए which is safe, and then supervise. Initiate referral, and follow up is very important. Ensure that child comes to you for follow up. You don't have to be a therapist to make a difference. Your calm, caring response and timely action can definitely save a life. First responder toolkit for pediatricians: recognize red flag, by quick screening tool, communicate with empathy, referral and safety plan, follow up and support. When when to refer urgently, adolescent at risk for suicide, if they can be managed in OPD, fine. If there is any immediate danger of self, if it is, then and coexisting medical emergency also is there, refer to emergency care. And all these things, family unable to provide support, severe uncontrollable mental health, multiple high load risk factors, then they definitely warrant an referral. School and community role, adolescent mental health and well-being is in the central place, and school, family, pediatrician and community are four pillars. So they should make a safety net, and all the pillars must work in great cohesion, and they should support each other. This will provide a safety net which is very important for a optimal growth and safe space for students. Congratulations to Supreme Court, which has recently come out with a verdict in 2025 only and had made mandatory the helpline counters, required anti-hanging measures, which has been started. Teaching of emotional resilience module for students is now mandatory. Annual mental health audits in each coaching institute has become mandatory, and now if implementation begins with penalties for not compliance. So friends, take home messages is suicide and self-harm are preventable. Pediatricians are the gatekeepers and early intervention changes everything. So I once again congratulate the topic. I'm really impressed by the topic kept for this talk today. Every child's life is a story is still being written. As pediatricians, we hold the pen that can turn a chapter of pain into one of hope. These are the references. I must congratulate Preeti for this guidelines or adolescent mental health in 2022. It was published in Indian Pediatrics, a wonderful asset for all of us. Thank you very much. Behind every statistics is a young life, is safety, and a future that deserves to shine. Thanks for making adolescent mental health a priority. Together, as pediatricians, mentors, and advocates, we can hear the silent whispers and turn them into voices of hope. Thank you very much.
Thank you very much, Dr. CP. And this was a really very good informative. And the red signs and the carry home message is very clear that we as a pediatricians can do a lot more to these children and also to the society and others. And we should take it as our priority for the future of this nation, who are these children, who are the future of this nation. Thank you very much. And over to the MC about the questions and others, please.
Are there any questions on the topic, please? If not, we can move on to the next session. Thank you, Bansal sir, for your insightful presentation on identifying.
Yes, congratulations, Bansal. You've done a wonderful job.
Thank you so much, sir. Hearing this from you made my day. Thank you.
CP, I would also like to add, fantastic lecture.
Thank you so much, madam. It's all your and sir's teaching we are today.
No, you are better than the teachers.
we can never be.
Bansal, it was great, huh? Lovely talk, Bansal. I'm sure you're doing a lot for the children in your area, and I hope we can do as much. Thank you so much.
Thank you.
Sir, your slides are fantastic, sir. Slides are so expressive and so passionate. They look.
Thank you.
The passion.
Over to you, Dr.
Shweta?
Shweta.
Okay,
Shweta.
okay, sir. Okay. Sorry, sir. So, once again, thank you, Bansal sir, for your insightful presentation on identifying early signs of suicide and self-harm. And special thanks to Dr. Kamath sir for chairing this session. The next session is on management of suicidal behavior, the role of pediatrician. This session is being chaired by Dr. Shajit Thomas John sir, doyen in the field of adolescent health, Head of Department of Pediatrics and Neonatology, BMH Kozhikode, past chairperson of Central AHA, past state president of IAP Kerala, and founder of DOSE Foundation. May I welcome you, sir, to chair this session.
Thank you, Dr. Sweta, for the introduction. I must first of all congratulate the organizers for bringing up this wonderful, very pertinent topic, which is very important. In fact, the incidence of suicide is rising year by year, not only in India, but in many other parts of the world. As Bansal sir, he has given an excellent lecture on that with very good slides. He has given the incidents and he has given you a brief about what this is all about and why we have to go ahead. And then to talk about the management of the suicidal behavior, what is the role of pediatrician? Well, the pediatrician has to identify, he has to assess, and then implement safety measures. And to talk on this topic, we have got a very knowledgeable person, Dr. Preeti Galagali. In fact, she's my classmate for PGDAP. So nice to chair the session by her. Preeti is a consultant adolescent health specialist, the director of the Bangalore Adolescent Care and Counseling Center, clinical lead in Adolescent Clinic, Manipal Hospital, Bangalore. She was the vice president of the South Zone Indian Academy of Pediatrics right now, this year, 2020-25. The vice president of the Southeast Asia International Association for Adolescent Health, 25 to 28, co-chairperson of Education Committee, 22 to 25, co-chairperson Scientific Committee World Congress on Adolescent Health, 2025. She was the chairperson of the Adolescent Health Academy in 2019. She has more than 200 scientific talks still going on, more than 100 scientific publications, and then she's done a lot of community work also. It's a lead author of the first IAP clinical guidelines on adolescent health and the associate editor of the first IAP book on adolescent health. So here it is. I request Dr. Preeti Galagali to talk to us, to take over, and the management of suicide behavior and role of pediatrician. Over to you, Preeti.
Thank you, sir. Thank you very much. And I congratulate you on your numerous achievements. Especially, there is nobody to beat you in the field of Down syndrome, I feel. And it's an honor and privilege for me for having you chair this session. And warm salutations to my gurus, Dr. Swati Bhave Madam, Dr. MKC sir, Dr. Bansal sir, and all of you who have encouraged me over the years to practice and share my knowledge about adolescent health. So I must say right in the beginning that there may be some overlap with Sir's fine talk on risk factors and management of adolescent suicide. But I think it's all taken in the good spirit because Jaan hai to jahan hai. We all know that if there is life, then there is everything. And so what I'll be talking today is about the first level response in office practice. I know that there are many cases of organophosphorus poisoning admitted in the ICUs and that to adolescents. I also know many come with asphyxia due to hanging. So I'm not going to touch on those. What I'm going to touch is in office practice, what can we do? But I think the principles that I discuss now can very well be also implemented in ICU practice. As Bansal sir already said, there has been a surge in suicides in India all over, and the paper that he was mentioning, this graph is from that paper, and as you can see that adolescent suicide and in all children, suicide amongst children is on the rise from 1995 to now.
and one student commits suicide every year. These are not statistics which India is proud of, and how can we turn around? Actually, Indian Academy of Pediatrics first started talking about suicide under the guidance of Dr. C.P. Bansal himself and Dr. Tuteja, and they motivated us to start Mission Kishore Uday 2, and under the IAP Presidential Action Plan of Dr. Santosh Sowans and Dr. Digant Shastri, we launched this program reaching out to pediatricians, to the community, and also to parents. So it was a very, as you can see from the statistics which I have put on the screen, it was a very successful program. We further went on with the encouragement of Dr. Piyush Gupta and Dr. Digant Shastri and of course MKC sir to go and publish the first IAP adolescent health guidelines, and this happened during the pandemic. We reviewed 183 national and international scientific papers and documents, and you can see the team here, and many from the team are there on the online platform today. Thank you very much. It was indeed a very fascinating experience, and we went on to publish the first IAP guidelines on adolescent health, on guidelines for adolescent-friendly health services, and also on management of suicidal behavior in adolescents. And what I'm speaking today is mostly from these guidelines, and I would really suggest all of you to go through these guidelines and follow them and implement them in your own practice. Further, Dr. Ramesh Kumar asked us to prepare the SDGs for teen depression and suicide. So this is just in 2 pages what a IAPN should be doing. Again, please read it. And the first book on adolescent health was published, which also has a very good chapter on management of suicide by me and Dr. Amita. So a lot of stuff available for pediatricians to read, and we have tried to make it more concise and brief. So in the next few minutes, we'll say what is the role of pediatrician, what is the clinical approach, what is the cascade of emergency care, which follows the acronym QPR, just like CPR: question, persuade, and refer. Case discussions, prevention strategies, and a word about the National Suicide Prevention Strategy at the end. So for the last 1 decade, suicide has occupied either one or second common cause of adolescent mortality in India. We all know that adolescents have a highly reactive limbic system. They are emotionally labile and impulsive, and they have poor stress management strategies. And also there is the immaturity of the hypothalamic pituitary adrenal axis, and there's a storm of stress hormones, and hence they're not too good in managing stress. And on that, we also know that there's a suicide contagion which occurs in the adolescent period. If someone commits suicide in a college or in the family, the adolescent who's facing a similar stressors may also try to commit suicide. And hence the very important is responsible media reporting and to give postvention to adolescents who have experienced a suicidal behavior in their peer. And that is the reason why Indian Academy of Pediatrics recommends at least annual screening for adolescent suicide. We know adolescents have a poor health-seeking behavior. Only 1% of adolescents with mental disorders actually seek medical help. There is a 75% shortage of mental health professionals in India, and we as pediatricians need to pitch in, and there has to be a task shift approach so that even all health professionals have some basic idea about managing suicide. We all are aware about the too much of mental health stigma and the parents and the adolescents' hesitation in seeking help from mental health professionals. We all know that they have an excellent rapport with pediatricians, and hence we should be able to pitch in with the basic first level care for any child with suicidal behavior. And 50% of mental disorders present before 14 years of age. And as Dr. Bansal said, that mental disorder is a high risk for suicide, and we should have our antenna up to screen for risk factors, screen not only for mental disorders, but for mental distress also. Take special care of vulnerable groups. And these are the groups who have neurodevelopmental disorders, who have genetic disorders, chronic medical disorders, Also, those who have suffered from adverse childhood experiences, they are also those who are in institutions, those who are on orphans, those who are on the street. They need to be specially screened for risk factors for suicide. And a previous history of suicide attempt or of non-suicidal self-injury is also a very strong predictor of suicide in the future. So as pediatricians, we should be screening. Unfortunately, we do not pick up the warning signs in time. And it has been shown by studies that 4 in 5 who ultimately go on to commit suicide actually have given warning signs and have actually met a health professional who has missed these signs. And lethal means in India are amongst adolescents are usually hanging, poisoning, self-immolation, and drowning. So this is a fantastic infographic, and I would again recommend all of you to go through this paper, which gives the causes of suicide in India over the entire lifespan and what is more common in different phases of life. So as you can see, going on from childhood to adolescence to young adults, academic failure, abuse, trauma, bullying, stigma, minority stress, sexual violence, substance use. And then there's a mix over the various ages, intergenerational conflict, interpersonal problems, early and arranged marriages. So girls are at risk of committing suicide because of these early marriages and because of gender discrimination in India. Marital conflicts, domestic violence, physical illness, and chronic pain. And there are some factors which extend over all the age groups, and these include depression, financial insecurity, very, very common, absence of social support, family history of suicide, chronic stress. It could be psychopathology amongst the parents like depression or alcohol use disorder, community-wide discrimination regarding gender or caste. So the causes help us to plan prevention programs. Dr. Bansal talked about risk and protective factors, and I'm going to just emphasize on those protective and risk factors which have been shown evidence-based in preventive efforts. So if there is availability of physical and mental health care for adolescents and restriction of lethal means of suicide, the incidence of adolescent suicide really comes down. The second important thing is treatment for mental illness, treatment for substance use, previous suicide attempt, and also help to overcome impulsivity and aggression. 90% of adolescent suicides are impulsive. So we should be taking care of that as well. Then supportive relationships with healthcare providers and also life skill education. So these are the three things which we should be focusing up on in the society, in the individual, and in relationships. And as we know that this is multifactorial, so we should be attacking different domains of an adolescent's life. Now, this is an important slide. What do we do in history taking an examination if we have a child who presents to us with suicidal behavior? And when I talk about suicidal behavior or of self-harm, I am including both the intention to die and the intention not to die, which Dr. Bansal said was non-suicidal self-injury. So the self-harm covers both these. So what do? We should have a very empathetic attitude. We must offer privacy. We must also tell the limits of confidentiality, saying that if you divulge anything which is harmful to you, I may feel the need of discussing this with others in your life, but I shall take your permission before doing so. So have you understood what have I said? So this is very routine, and it should be said even in a case of self-harm. Documentation, documentation, documentation. Remember, this suicidal behavior has medical legal implications. So you must document whatever you are eliciting in the form of history or a physical examination. You must ask questions about ideation, thought, intent, and plan, because this is going to really determine how your emergency response is going to be. Must ask in the head screening for a precipitating event, life goals, reasons to live, and risk and protective factors. Also need to screen for comorbid mental disorders, high risk behavior, like use of drugs, risky driving, sexual promiscuity, sexual relationships, which are really unhealthy media use, also chronic medical disorder, and also screen for online sexual solicitation. Past and family history of suicide attempt, non-suicidal self-injury, mental disorder also need to be screened. We also need to screen for chronic medical disorders like diabetes, epilepsy, asthma, and also check on their control, because adherence is often a problem in the adolescent period. Mental status examination and a systemic examination are extremely important. We should be familiar with the DSM-5 criteria for mental disorder, but we have simpler tools which can be used, like the Beck's depression inventory and the PHQA for depression, the SCARE tool for anxiety, the screening to behavior intervention tool, and the CRAFT tool for substance use, the ASK4 for suicide screening, and ISPATH for acute suicide risk. So this is what you need to have handy in your clinic. So the ask tool was already discussed, but I think the most important question is that, are you having thoughts of killing yourself right now? For those of you who do not want to use the ask screening tool and you feel it is cumbersome, even though it has only 5 questions, you can also ask a question. At times things get difficult for adolescents, and some adolescents think of ending their life. Has this thought ever crossed your mind? So this is a good question to ask. And if they say yes, so have you ever attempted to end your life? Are you having a plan now? Because if the adolescent is having a plan now, that is a very, very high risk for suicide. And you all know that the adolescent brain is extremely impulsive. The acute suicide risk is screened by the ISPATH worm, which Dr. Bansal has already talked about. So this is an easy mnemonic to keep handy, either on your phone or as a handout in your clinic. So when we do the risk assessment, low risk is if an adolescent have only thoughts. Yes, sometimes I feel things get very difficult and I feel like ending my plan. I feel like ending my life, but doctor, no, I may not do it because my parents love me a lot. Okay, so the adolescents having thoughts, the moderate risk thoughts with intent. I feel I would be better off dead because nobody likes me in the house. Have you thought of a plan? No, I don't have a plan yet. Okay, so that means it's a moderate risk. Severe risk, life has become so terrible, I feel like hanging myself, doctor. So that is the suicidal plan. Now, if there are warning signs of suicide, if there are multiple risk factors, there's a past history of suicide, there is psychosis, substance use disorder, severe mental disorder, and refusal to follow the safety plan, then even if it is low risk, it is considered as high risk. And why is this risk assessment important? Because we in the Indian Academy of Pediatrics guidelines recommend that all adolescents of suicidal behavior must be referred to the psychiatrist. It is how quickly you do it is dependent on your risk assessment. So if there is a plan to commit suicide, it is an emergency. You have to get a psychiatrist immediately on board, and if required, in interest of safety, also hospitalize the adolescent. But if there is not a high risk, there is only probably non-suicidal self-injury with low risk, then you could just write a referral for the psychiatrist, call the psychiatrist and say, please give an appointment within the next 48 hours, because you know, child and adolescent psychiatrists are also busy people. Please keep in touch with the psychiatrist and please document everything, because as I said, this has medical legal implications. So what is the cascade of care? Of course, if there's a wound which is bleeding, you need to give emergency medical care. You must break confidentiality to a trustworthy adult which is selected by the adolescent. You cannot tell your father. The father may be the one who's sexually abusing the adolescent. So you have to ask the adolescent before breaking confidentiality. You counsel the adolescent and the parents. What do you do? As Dr. Bansal said, active listening, validate their emotions, instill hope. reassure them, impart psychoeducation that how the adolescent brain is impulsive, appreciate the strengths, and also arrange for a mental health referral. The safety plan, I'll be talking about it in a minute. The safety plan actually tells about the warning signs of mental distress, activities that an adolescent can do to overcome that mental distress, people who can help, and what makes life worth living. Lethal means counseling is very important. For example, if an adolescent has used Harpic to commit suicide, that Harpic should be either removed from the house, that is the best thing to do, or keep it under lock or hide it. Locking and hiding has not found to be very effective, so they need to remove it. And if it is, for example, an antidepressant, which they or somebody else is using, maybe it needs to be locked. So these are some of the things which we have to be very careful about. And the FAN, which is anti-suicide, which we already talked about, is also one of the lethal means counseling. We need to collaborate with mental health professionals. Any case of suicidal behavior has to be followed up at least once a week for the first 2 months, and then at least once a month for 1 year, and at least twice in the second year. So this is what we have written in the guidelines. We need to maintain a close follow-up and partner with the mental health professionals. It is an excellent idea to share these helpline numbers with the adolescents. You know, adolescents sometimes do not like to come to us, but if we offer them these numbers, which are by the Government of India, they may seek help. And by the way, Telemanas has been shown to be a very, very effective strategy of the Government of India, and they have had millions of calls since it was started for helping for suicide. So let's come to a few cases. A 15-year-old girl with poorly controlled bronchial asthma with poor adherence to inhaler therapy. And this happened just a couple of days ago. And while I was examining her, I found this. So what are these? What are these? These are self-inflicted injuries. And when I started talking to her, she said she lost her father 7 months ago, and she really was very, very attached to him. And she's missing him a lot. She's missing him so much that she is not able to concentrate on her studies. Yes, her mother is a fantastic support, but she does not feel as close to her mother. She is religious, she loves music, she loves dancing, but there has been a drop in her academic performance. Her teacher has been scolding her, and whenever her teacher scolds her and she misses her father, to cope up with this stress, she cuts herself. Her screen for mental disorders was negative, and you will all agree with me that she will need a referral to a psychiatrist, which I did, and she is actually going to be seeing a psychiatrist on Monday. So if we put this all together, taking care of even Tdap, the vaccination, the wound care, and also dealing with her asthma, you know, stress itself could cause uncontrolled asthma, and she was not willing to actually take the inhaler because she said she wants to be with her father, but at the same time, her ambition was to be successful in life and live her father's dream. Her father wanted her to either become a doctor or an architect. So there was a purpose of life. Now, can you understand the dialect here? Dialect are two opposing things. She wants to be with her father in heaven, and she wants to live her father's dream. So this is what we are going to tackle as we go along. So this is a sample safety plan, and I have a printout of this in my clinic, which I keep. And I'm going to show you the safety plan which she filled up. So see what she has written. Triggers. I want to be with my dad. When I face that I am the life is disappointing for me because I'm not doing well in studies. And when I remember my father's last moments, I feel like killing myself. Then how will you overcome these thoughts? By something which you can do. She said singing, dancing, even crying. And I was not very happy with the crying option, but she said, "Doctor, if I cry for 5 minutes, I feel better. Believe me, I don't cry the whole day." And listening to music. Then she said, people who could help you and places that can help you. She said, talking to friends, and Armin was her best friend. She said, going to the terrace. Again, I was not happy when she said going to the terrace. She said, "I know what you are thinking, doctor. The whole terrace is covered. And even if I wanted to jump, I couldn't jump from there." And then she said about badminton, which she loved to play, and there was a badminton court in her gated community. So this is how was her plan. And people whom I can ask for help, Armin, her phone number she didn't remember orally, and she said, "I've left my phone at home for coming and talking to you, but I'd like to know your number." So you can see my number there. And you can also see doctors, clinic, hospital helplines. So I've written the Kiran helpline. I've also written the Nimhan's Telemental Health helpline. And reminder, I am precious. My life is precious. The one thing that is very important for me and makes my life worth living for is fulfilling my dad's dreams. And see, the signature is here. It's her signature here, mine here. And then we got her mother in, and I broke the confidentiality, and I got her signature also later. So safety planning intervention is evidence-based. It decreases the next risk or the next suicidal behavior by nearly 50%. So as a pediatrician, not even a one who's interested in adolescent health, I think all pediatricians can do this very, very easy. Remember, I talked to you about dialects. Now, dialectical behavior therapy is what the psychiatrists usually do for such adolescents. This is also evidence-based, but many of our adolescents, they do not go to a psychiatrist. So I said, you must refer all. Sometimes they don't go, even you have documented, taken their signature, they say, you come and do the counseling. So what do you do? What are the basis of dialectical behavior therapy? It just is built on the premise that adolescents are emotionally sensitive, reactive, and when the stress goes up, they are slow to return to baseline. And there'll be maybe invalidating environment. Like in this case, there were her teachers who were always scolding her, and her mother was always telling her, don't cry, come out and play with me, come out. So she was not understanding that she was bereaved. She needed that time for grief, and she was unable to reach out to her and share. And because of this, there was high emotional dysregulation. So what are the components of dialectical behavior therapy? There are emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness. Now keep looking at this very, very carefully, and you will realize that we have been actually in adolescent medicine doing all this. Have we not been doing problem solving? Have we not been teaching the children coping with stress, coping with emotion, good interpersonal communication? We have always been telling adolescents to have a hope box, things which make me hopeful, my dreams, my aspiration, my parents' dreams. We've also been telling them to self-soothe themselves by probably touching something, maybe a stress ball, maybe smelling a perfume, to have a band and to remember the person who means most to you. And all this comes under life skills. You all know about the Thirsty Crow story. You also know about the Thirsty Crow story if it was a gang. So all the 10 life skills are extremely powerful to teach any adolescent with self-harm behavior. Let me come to case 2. So what do you think? What is the risk assessment here? As you can see, the adolescent has drawn herself, and there's intense sibling rivalry. She has put herself in a jail, and she has written down there, they hate me. And here she is actually threatening to commit suicide. So this is imminent risk of suicide, immediate referral. Sometimes adolescents may not talk. The parents may get you such drawings, and you have to act immediately without any thought. You have to get a psychiatrist on board and even admit this adolescent. I've often shared this story with you, and an adolescent rang me up on the phone saying, I'm standing at the balcony and I'm going to jump. So adolescents may not walk into your clinic, they may even ring you up. And then what is the next question? You be empathetic again, non-judgmental. What happened? Oh, doctor, I came back from my school today and my mother saw me talking to this boy and she called me a prostitute. Doctor, tell me, if your mother calls you a prostitute, life is not worth living. And I quickly told her, if you have a 100 rupee note in your hand and if you crush it, what would be the value of that note? She said 100. I said, if your mother calls you a prostitute, does it make you one? She said, no. Should I be talking to my mother? I said, of course. And all that I wanted her was to shift away from that balcony. She went on, she gave the phone to her mother, and I told the mother, please spend this evening with your daughter. And that was a turning point. And she is now a chartered accountant and she gets her baby to my clinic. So it is all a partnership between us, the parents, to keep the adolescents safe. Prevention interventions, we are doing a whole lot of life skill programs. Also selective interventions for parental and adolescent psychopathology are recommended. Warning signs, of course. It is a time to do a lot of advocacy. See, many of you don't know about these guidelines. So I would recommend that all of you please go through these guidelines. Of course, national policy is there. We need to do more research. We need to document. There should be a registry for adolescent suicides. Poverty alleviation, gender equity, exam reforms, regulation of sale of insecticides, media reporting guidelines are all very, very important. We have a fantastic national suicide prevention strategy which talks about a multi-sectoral approach with a lot of partnership between local health services, the community, and also different ministries. We have RKSK, the school health program by Ayushman Bharat, the Sarv Siksha Abhiyan, the National Mental Health Policy, National Youth Policy, National Mental Health Care Act, which has decriminalized suicide, and the suicide care should be by the government. We are going to have this book on adolescent counseling being released next month. I'm very fortunate to have been a co-editor with my teacher MKC Nair sir, and this would give about suicide counseling, also about dialectical behavior and more. So
Preeti
I
ma'am,
thank you
we are
very much for promising me to validate feelings, reassure, building up hope, to plan safety intervention, to do mental counseling, parental counseling, for a mental health referral, and follow up. So it's all about partnership, and the International Adolescent Health Week is emphasizing this once again: thriving inside out, strengthening adolescent physical and mental health. And we had the first program yesterday at Mysore Kaveri Pedicon, where I partnered with the International Youth Ambassador Sanjana, and we talked about demystifying adolescence and giving care for those with suicidal behavior. Thank you very much.
Thank you, Dr. Preeti. That was an excellent talk, very much detailing about what has to be done with examples and the practical tips. I'm sure it has benefited all of us. Are there time for questions, or Dr. Sweta, Dr. Deepa?
as we are running short of time, I think
Okay, then
we'll go
I
ahead
think
with this
we can move ahead.
third session. We'll have a discussion on this. Even if doubts, can put it on chat box.
Yeah. As of now, there are no questions in chat.
Thank you, Dr. Preeti ma'am, for the wonderful presentation as usual. And thank you, Shaji sir, for having chaired this session. Our next session is on risky behaviors in adolescents, addressing peer pressure and reckless activities. To chair this session, may I invite Dr. Himabindu Singh, our respectable chairperson of Central AHA. Ma'am is also the Dean of RGMC Government of Telangana and Yuva Nodal Officer. Being a Best Doctor State Awardee, she has adorned various positions in IAP, AHA, and NLM. Over to you, ma'am.
Yeah, thank you, Dr. Swati. It's my pleasure, absolutely an honor, to chair a session of none other than our Doyen in Adolescent Pediatrics, our dearest Swati Bhave Madam. Madam, are you able to hear me?
Yes, ma'am.
We can hear you.
Yes, ma'am, you're audible. Himabindu ma'am, are you there?
Hello.
Yes, ma'am. Yeah, ma'am.
Yeah. So, yeah, madam, I was introducing you, and madam is our president of IAP in 2000, was our president in 2000, and she's been an executive director of AKI, and she's the only professor of adolescent medicine in India, in our country. We are very proud of you, madam. She has done so much work, pioneering work in adolescent health, and we are all very, very proud of her. Most, actually, really beautiful person, both outside and inside. She's been an inspiring person for all of us. And we have learned a lot looking at the way she has managed her work-life balance and so many new things she has started in IAP. Our chapter was her idea, the adolescent health chapter. And I'm really blessed to chair this year as a Silver Jubilee chairperson. But it's all due to the legacy of all those who have worked for the adolescent health for the last 25 years. She was very, very instrumental to start our chapter. And our Aki, the NGO, is also doing great work. And she's been authored many chapters in many books and instrumental in many, many things. Over to you, madam. We would like to hear you. She's addressing a very important issue, how to address the high-risk behavior among adolescents. Over to you, madam. We all love to hear you. Please. And we are seeing her after long time. We bless her good health. We want her to be more frequently into our, in all our, whether it is IAP or AHA. We want you, madam. Please, over to you.
Thank you, Hema. Thank you for all the kind and sweet words about me. And I'm also honored that you are the chairman of my session. You have been doing an excellent work, and I'm very happy to see you as the chairperson of AHA in the Silver Jubilee year. And let's have a nice session. Can I share my slides, please?
Yes, ma'am. Yes, ma'am.
Yeah. So can you see my slides?
Yes.
Yes, ma'am.
Yeah.
Okay. Yeah.
Okay. So first of all, let me thank IAP Kerala, IAP Cochin, and the AHA Kerala, Jason Uni and Deepa Janardhan Ranjit for having invited me in this wonderful CME. I will not be taking all names because I don't want to miss some names, but all the organizing team, thank you so much for organizing this wonderful CME with these excellent topics and great chairpersons and speakers. So today my topic is risky behaviors in adolescents, addressing peer pressure and reckless activity. This presentation has been prepared jointly by me and Dr. Prashant Karya, and the slides which I'm projecting is taken from a joint module of both our NGOs, Yuva Mitra of Prashant and Association of Adolescent and Childcare in India, AKI, by me, where Prashant is also National Forum Youth Coordinator. So what is going to be the session? I would like to explore why adolescents engage in risk-taking behavior, identify common types of teen risk behaviors, understand the concept of what is peer pressure, recognize different forms of peer pressure, teach strategies to resist and handle peer pressure, making adolescents empowered and strong to deal with situations, define the supportive role of teachers, highlight how parents can guide and support, and emphasize community involvement in teen well-being. So let us discuss or define what is meant by risk. Risk is the possibility of a negative outcome resulting from action or situation that involves uncertainty or danger. And risk-taking behavior refers to actions that involve a potential for harmful consequences but are performed either for thrill, peer approval, emotional coping, or curiosity, especially when the individual underestimates the danger involved. And you can see the risk-taking behavior of poking a lion, which is a very risky and thrilling behavior. I don't know, I can't go to the next slide. Any problem? Deepa, this is creating problems for the...
Can you just try minimize and just come back once?
Okay, I'll do that. No, I think it's just stuck. Shall I again log out or something?
You can stop sharing and then do minimize.
Okay. No, it is still stuck. Deepa, can you run the slides? I don't know why it's getting stuck.
All over again.
Yeah,
Start
I got
again.
it. Yeah, thanks. So let us first discuss, why do teens take risks? So first, all of you who are aware of the brain development of adolescents know that though legally at 18, an adolescent is considered an adult, he can drive, he can vote, he can also drink in some states. But the prefrontal cortex, which is in charge of logic and judgment, is still under construction. And amygdala, the emotions, thrill, peer approval, takes the driver's seat. And hence, whenever an adolescent is especially under peer pressure, he's going to have a dopamine rush, which is a reward pathway, which comes from social media, rebellion, and thrill. And so we all know that adults will have a top-down control from the prefrontal cortex. So whenever adult feels like doing a high-risk behavior, or he's tempted or asked by others to indulge in high-risk behavior, his prefrontal cortex, which has abstract thinking, will rationalize, okay, if I do such a thing, what will be the negative consequences? And that helps in the impulse control of adults. Though, of course, we have seen many adults who still behave like adolescents and indulge in risk-taking. But we are talking of normal adults who are mature. In teens, there's a down-up control from the limbic system. And hence, we know that the emotional brain is predominant. And that is why taking risks and having risky behavior is part of adolescents growing up. So what are the common risk-taking behaviors? Experimenting with substance abuse, participating in bullying or violence, speeding, rash driving, driving under influence, and risky stunts, and succumbing to negative peer pressure in spite of good moral values and judgment coming from a very secure home. And we know that even older adolescents whose thinking has gone from concrete to abstract, that means they can see the consequences of their actions. When they're in a peer group, the peer pressure can make them regress to concrete thinking, and without any other thought of action, they will indulge in negative behavior under peer influence. Unsafe sex, sexting, and unsafe and toxic relationships are starting very young now. And I'm doing purely adolescent practice for the last 25 years. And I'm seeing a lot of romantic breakups and toxic relationships, which may start as early as 8 to 10 years. So they're really precautious in their romantic development. And cyber crimes, either adolescents are victims of cyber crimes, or some tech-savvy adolescent may indulge in cyber crimes themselves. So fake online identity theft, bullying on social media is very, very rampant. And added to all this are the various challenges and risky dares from social media. So if you see the various studies, if you see GYTS 2019, children aged 7 to 17, Government of India, we show a high number of people who are indulging in substance abuse. And this is the tip of iceberg, because many of them may not confess or accept of this high-risk behavior. These addictions pose serious threats to adolescent health, safety, and well-being. So let's do some literature survey. Are the adolescent behavior too risky? This is a school-based survey in the district of West Bengal, India, where the prevalence of physical fights was 27%, weapon carrying was 7% in the last 30 days. Gang fights were 13% in the last 12 months, and current uses of tobacco, alcohol, and illicit substances was high. Association between smartphone addiction, parental styles, and mental well-being among adolescents aged 15 to 19 years from Gujarat. And this showed that smartphone addiction was seen as high as 64 points. And now all of us who are doing adolescent practice, it may be as high as even 90%. Increased risk was seen when there were urban teens from high socioeconomic group, high parental education, especially graduate fathers, and using smartphones for more than 3 years. I guess they get more and more tech savvy and learn to use the apps and become more proficient in it. A South Indian study showed peer influence and its impact on behavior among South Indian adolescents. And as has 43.9% reported high peer influence. Again, all these statistics are the tip of the iceberg, and I'm sure the statistics actually are far higher. So let us go to some illustrative cases. A 15-year-old boy ended in the ICU because his friends dared him to ride on the top of a moving school bus for 10 seconds. Was this risky? Most definitely. Was it preventable? Absolutely. If this child in school had got awareness programs conducted about peer pressure and risky behavior and had attended a life skill education program by WHO Life Skills, he would have learned the coping skills to prevent negative peer pressure. And if his home, the parents had good communication, they would also be discussing about not taking these risky challenges which are rampant on social media. Coming to our next one, 13-year-old male who had an arm fracture after a road traffic accident. The patient attempted to ride his bicycle downhill with no brakes as a part of a YouTube challenge. He was cheered on by his friends who recorded the stunt. He lost control and collided with a parked car. Social background, he was a regular user of Instagram, YouTube Short, eager to gain online popularity. He had low parental supervision and high need of peer approval. And again, this case could have been prevented by attending awareness programs in school and close communication and bonding with his parents. Substance misuse due to viral trends. And this is a risky experimentation due to peer pressure. A 14-year-old boy came with altered sensorium and vomiting, saw tequila challenge on Instagram. Friends dared him to take 6 tequila shots during a sleepover. Parents noticed confusion and lethargy the next morning. Good academic performer, but easily influenced by peers. This case highlights many other points. Many parents feel sleepovers are more safe than sending the child out somewhere where they have no control. But when you say sleepovers, it is expected that the parents in that house do not walk out of the house and keep that house totally free for the teenagers for sleepovers. And I always advise my clients that if somebody is going for a sleepover, you need to talk to the parents of the house where your child is going, and you need to ensure that the parents are going to supervise a whole batch of teenagers who can do any risky behavior when they're unsupervised. So we need to understand that even sleepovers have to be supervised, and you can't keep a gang of young boys or girls free to do whatever they want in risky situation. And this is like an acute alcohol intoxication. And this boy was lucky, but I have had cases where children going for sleepovers, the child had a lot of tequila shots and the child was unconscious in coma. But the friends thought that he's sleeping and it is better to let him sleep because they were afraid to tell their parents or ask for adult help because they had done all this lying and cheating to their parents and they didn't want that to be known. And next morning, this child was found dead. And hence, it is very important for us to understand that acute alcohol intoxication and this high-risk behavior needs to be told to children either through parents, teachers, or workshops in schools. Third is a substance experimentation. A 15-year-old female came with persistent cough and wheezing, admitted to using e-cigarettes at school regularly for the past 6 months, started after a best friend group introduced her to vaping, believed it was harmless and cool. There was a drop in academic performance, and frequent absenteeism. Now, this also brings out very many things, that how can a child be exposed to e-cigarette or vaping in a school? That means there is not good supervision in the school. Some years back, in a Delhi school, the parent found vaping the equipment in his son's bag, and he reported to the principal, and they had a surprise raid in a lot of those schools. At least 60% of children were found to have vaping instruments in their bag. And hence, it is so very important to understand that unless we have awareness programs in school, many children today are going for vaping because they think electronic cigarettes are very harmless and cool. But we know that some of the dangers of electronic cigarette far outweigh even ordinary smoking cigarettes. So we have to, again, this could have been easily preventable if there was good supervision in the school and checking that such things are not brought into the school. And if this child was doing vaping, is it generally in the school toilets, where generally they don't keep CCTV cameras, but still there has to be some monitoring in school toilets to see whether children are vaping or smoking during the lunch and the tea breaks. A lot of children today are online, and parents are taking a lot of care to see where they are going because they are so worried about the outside world. They are keeping track. They have apps which can monitor the family location, so each member where is he. But they forget one thing, that they feel the child is very secure in the four walls of the house. And often this child is kept alone in his bedroom with complete privacy and a smartphone or a digital device. And they're not realizing that danger is entering into the rooms, into the bedrooms of the child if they are not undergoing parental supervision. And hence, we have to do a lot of parenting programs for digital monitoring, how to be a tech savvy parent, and how to understand what digital activities the child is performing. And Dr. Michael Rich, I'm sure, will give a wonderful lecture on all this. But what is important is that many parents who are especially not tech savvy are absolutely unaware of what the child does online, and he does not know which sites he's visiting. And this case, 16-year-old female, she came with anxiety and crying spells. This was my patient, and the mother brought to me because she was not talking to anybody else. And she had been chatting with a person online who posed as a 17-year-old boy. And we all know about catfishing, where they assume an identity of a person, make the other person completely trust him, and then engage into risky behavior. So she shared personal intimate photos of herself after the boy also had, so-called boy, I'm sure he must have been an adult or a pedophile, and then he started blackmailing her. Now, this is something which we always tell parents, and in my workshops in college and school, I tell them that first of all, what is online behavior versus offline behavior? Don't do anything online which you will be ashamed to do offline. And many children feel that the web is anonymous, and they have to be made to understand that once you put something on the net, it can be retrieved at any time. It's a digital footprint, and you're not anonymous. You can be traced. The IP address can be traced. And when the first blackmailing starts, we tell the children that you have made a mistake by risky behavior. Now, don't compound it by getting a victim of blackmailing, because sooner or later, you will have to take help of your parents, and your parents will have to take help of the police. So it is better to overcome all your shame or guilt or whatever negative feelings, but confide in your parents that I have made this mistake of sharing inappropriate matter or pictures online. And now this ex person, I don't know, or known person to me, is starting blackmailing me. So please help me because I don't know what to do. And the parents have to understand that instead of shouting and castigating and telling the person we are ashamed of you, this is not the time to give all these negative responses to the child, but assure the child, yes, we know that you have indulged in risky behavior, but we are here to protect you. And now don't get caught into the blackmail, and we will take appropriate action. We will refer to cybercrime, take help, but don't worry, don't succumb to the blackmail. I have get countless patients, especially young girls, who are succumbing to blackmail, and I've helped them to go to the cybercrime cell. So let us discuss what is peer pressure. Some statistics: 82% of Indian youth face peer pressure in some form or the other. 68% make career choices based on peer or family. This is from Ministry of Skill Development. 85% of high school students admit peer pressure influence in all their decisions. 75% have tried alcohol due to peer influence. 28% of those affected by peer pressure report improved social status. So it's a dual-edged nature of peer pressure. And then what is peer pressure? This is an influence exerted by a peer group to behave in a way that is accepted by them. This is generally driven by a need to belong or to be liked and fit in. And majority of adolescents want to fit in and have a social status in a school. And this social status generally comes from a gang, which is doing very negative, risky behavior, but they are the elite or the top popular children in the school. And peer pressure is very common in settings like schools, colleges, social gatherings, or homes of friends. Why is it so strong? Adolescents spend far more time with peers than family and have a strong desire to be accepted and appreciated, and fear of rejection or isolation can lead to confirming behaviors. And in our parenting workshops, we say that if you don't like the friends of your child, the best way to make them go more towards the friend is saying, I don't like your friend, stop friendship. I want you to not allow this child to come to our house. Because the peer has chosen by the child because he finds something good in them. So in fact, I always tell them, start with a positive note that, I like your friend. He has got all these good qualities. First, list all the good qualities. But, I'm little worried about your friendship with him. And then the child says, why? Then you say, because he has experimentation with alcohol or he is involved into violence and bullying. And I'm worried that you will go down the same path, or even if you're a silent spectator, you will be party to his crimes. So what can you do to solve this? And then you can ask the friend, your child, that yes, you like this peer, continue with him when he's doing good activities, but try to avoid being partner in his bad activities. And if possible, I've seen that children can reverse pressure and change the bad habits of their peers, which is called positive peer pressure. So instead of saying that these are bad friends and blaming, because most parents will blame that, my son is a wonderful person, my girl is very good, but this is the peer pressure, she's got a bad gang. So don't blame others and peer pressure. As parents, you can always make your child very strong to choose the right peers and not to succumb for pressure. So let's talk of, when we talk of peer pressure, it's generally taken a negative form, like a negative peer pressure, but we have to emphasize on the positive pressure. Positive pressure pushes to do the right things and is generally good, and negative pressure, as we all know, pushes you to do wrong things and is often dangerous. So what is good peer pressure? This is being pushed into something which you didn't have the courage or the motivation to do alone. And we all know that if you have an exercise buddy, if you have a study buddy, it makes you motivated for doing better. And if you have friends that convince you not to do something dangerous, that involving in risky behavior or taking unhealthy lifestyle, which is not in your interest. So peers can stop you from risky behavior. They can stop you from taking part in bullying and violence. They can motivate you for healthy eating, healthy weight loss, and hence peer pressure is always good. And I always tell parents that peers are a very necessary part of your children's life, and nobody can replace peers, and you cannot do away with their friends, but you have to see that they have safe and good friends. And how can you benefit from good peer pressure? Children have good friendship, connectedness, socialization, encouragement. They can learn something new and have a good experience if that peer is good in music or singing or trekking, and they can overcome a fear. If a child has a difficulty in social networking or socially talking, the peers can help him to open up, improve his communication. And peers are your safety net. Avoid breaking the law, getting into trouble with your parents, and hurting physical or mental health. What is bad peer pressure? It means being talked into doing something that you didn't want to do, but did anyway, because your friend said that you should, and because mainly wanting to be accepted by your peers. And as we all know that this leads to something unhealthy or risky, like drinking alcohol, driving under influence, drugs, smoking, etc. And even more important, it can lead to trouble with the law. Underage drinking and driving, road rage, violence can have an FIR. And I always tell the children that if you are wanting to go abroad, one FIR on your passport will have difficulty in you getting clearance from the police. So think very carefully before you go into juvenile delinquency or getting in trouble with the law. So what are the outcome of risk of peer pressure? I've already told this in the earlier slides, but very important is that this leads to juvenile delinquency, lying or stealing or bunking class, and this can also lead to breaking of the law and, very important, unsafe and toxic sexual relationship with the same or opposite danger. And we know the metabolic syndrome today of eating junk food. And if your peers are overeating or eating unhealthy food, then it's also going to adversely affect your physical health. And of course, all the high risk behavior is going to lead to mental health problems like addictions, depression, etc. So all of us who are working with adolescents do conduct workshops, and we all are involved in life skill education training. And this is very, very important for helping adolescents to cope with their routine problems. I'm just sharing some of the slides which my NGO Aki uses for peer pressure programs. And we have all this based on life skill approach of WHO. So we present real life relatable situations to the group. Participants are encouraged to brainstorm and reflect on their responses. We teach them various styles of communication, and the focus is to understand what communication style they should naturally use. Is it assertive, passive, aggressive, passive aggressive, and what style to be used in various situations? As we know that we encourage the assertive style for all communications, but at times we may have to use a submissive or aggressive style depending on the situation. Then, after the role play is over, we ask the whole group to comment and do introspection. Did this style work in that moment to prevent peer pressure? What was the outcome? Was it positive or problematic? So, this brainstorming, the whole group discusses and they understand more and more about the role play. Then we give them a guided analysis that if this style didn't work, if you felt that this was not a very good way of handling, come on, what could have worked better? And we ask them, can you show a role play showing a better method? Show an alternative style which has healthier outcome. Such workshops build self-awareness of one's personality, of one's emotional reactions, and one's habitual patterns in communication. And this helps the participants to grow into self-confident, conscious communicators, whether it is at school and home, and the same assertive skills can also help them on online communications. So how to handle peer pressure assertively? We teach them that for every reason to say no, someone will find a reason to push you to say yes. And hence, be assertive and stand up for your decision. It is very important to say what you want to say assertively, to stand by your values, even if nobody is supporting your opinion. And have the assertiveness to make the argument and make the right decision. And whenever you know that there's going to be a big pressure and you may not be able to get out of a situation, like you know there's a rave party, think ahead and don't put yourself in the wrong situation. So what is assertive skills? The ability to say no when you want to say yes when you want to say yes, how to make requests and ask for favors politely, communicate feelings and thoughts in a very open and direct way without insulting anybody, without getting aggressive, and yet getting your way, how to handle put downs, how to form a social network which helps you to be rooted and supportive and have close relationship, friends who will stand by you in times of crisis and help you not to succumb into peer pressure. A lot of children do not know how to handle the put down and teasing by peers in a group. This bullying may not be very violent or aggressive or physical, but it is very emotional by constant pinpricks or teasing. And some children get into a lot of anxiety and even depression because they can't handle this peer teasing. So we have to train them to answer back assertively, answer in the same teasing manner. You can make a humor of the situation, should not devalue yourself because people are teasing you. Ignore the teasing, don't allow it to affect your normal life. Try to dissociate yourself from the person who enjoyed teasing and form another positive group where you are respected for what you are and you feel comfortable. But most important, adolescents have to be taught seek adult help if things are going out of control. And we often ask in our workshops that why, in spite of being bullied under peer pressure, why don't you talk to your teachers or why don't you tell your parents? And this is one, mainly loyalty, because they don't want to speak against their peers because it's called tattling. And fear, because if the group is very strong and a bully group, they are afraid of the consequences. So we explain to them the difference between tattling and telling. Tattling is getting somebody into trouble. When you're upset over a small thing, it aims to punish the other person or get the person into trouble, aims to complain or cause drama, stir unnecessary conflict, and very petty and attention seeking. On the other hand, telling is helping someone. When you see someone is hurt or unsafe, you have to help to protect or prevent harm. It solves a real problem, and telling is responsible and brave. And we all know that if a person has high self esteem, he or she is able to resist peer pressure far better. And hence, we have to take a lot of workshops for children to understand what is self esteem, what is self image, what is self worth, and what is ideal self, that is who you want to be. For example, if you see a cat looking in the mirror and wanting to be a lion, this is an unrealistic expectation or overconfidence. So you should not have over self-esteem or under self-esteem. And you have to be the real self, what you actually are. And if your ideal self and real self match, then you're very comfortable. You don't have to pretend and put on a mask to pretend to the world. So try to be as much as your real self as you can. Learn the art of saying no. It will save you from many problems and temptations in your present and future life. And this is what teenagers really need to know. So there are various strategies of saying no: polite refusal or no thanks, give reason, walk away, cold shoulder, broken record, give an alternative, own your feelings, avoid the situation, associate with supporters, or reverse the pressure. So these are some things we tell the adolescents in our workshops. These are the peer pressure situations, strategies that can be adopted, and possible answers. Would you like to come to a cinema? Polite refusal. No thanks, I already have a commitment earlier with my family. How about a drink? Give a reason. I don't like alcohol, tastes horrible. If somebody keeps on pressurizing you, come on, have a cigarette. We enjoy this, we do fun things together. Use the broken record. No thanks, no thanks, no thanks. If somebody says, hey, do you want to try some alcohol? It'll give you a high, it'll make you feel good. Walk away. Say no and walk away while you're saying it. If somebody says, shall we watch some porn movies tonight? Cold shoulder. Keep going as you did not hear the person. But walk away and cold shoulder cannot be done with close friends because it affects your relationship. But it can certainly be done with peers who are just your acquaintances and not close friends. We have to teach a lot of negotiating skills for young girls who should not be pressurized into risky sexual behavior by their so-called boyfriends. And we teach them these negotiative skills. Like if he says, will you come with me for a night show movie? All girlfriends would go with their boyfriends for outing. So you give an alternative. No, I rather stay at home. Why don't you join my family for a dinner? We can watch a movie on TV. It's a lovely movie. If the boy says, come on, just spend some time alone with me, you can reverse the pressure saying, what did I just now tell you? That I rather not be alone with you. I would rather be in a group. Weren't you listening? And again, you can own your feelings if they say there's nothing harmful from this. And many young girls are pressurized into sleeping with their boyfriend because the boyfriend says that if you really love me, you will do this for me. And then we teach negotiating skills to the girl saying, I'm not comfortable doing this. It makes me unhappy. If you really love me, then would you like to make me do something which makes me unhappy? And hence, girls can control the pressure which is being put to test their love and not enter into an unwanted physical relationship. In explicit high-risk situations like a rave party, just avoid the situation. It is best to be away because sometimes it's very difficult to succumb to this, or strength in numbers. You want to enjoy these parties, but you can have a group of very positive peers, like 7, 8 of you, who can resist the pressure, who can support each other, who will see that your drink is not spiked by someone there, and you can still enjoy the party, but this is not very easy to do. We can also teach them various models like stop and breathe, box breathing, think about the consequences, ask yourself, is it me? Respond with confidence. There are many, many strategies. This is just an example. So what is important also that has been put by both Preeti and CP Bansal, the high-risk behavior of suicide and how it can be prevented. Similarly, teachers can be a great help in preventing high-risk behavior. They can encourage assertiveness. Now, it's very funny that we want our children to be assertive, but whenever adolescents try to say something about their stand to teachers or parents, the answer they get, don't answer back, don't be rude, listen to what I'm saying. So if the child is not allowed to be assertive, if the child is not allowed to give his side of the story, both at home and in school, how do you expect that child to be assertive when he goes out in the real world? And teaching assertiveness starts at school and home, where teachers and parents should understand that if the child is saying no or is telling his side of the story or defending when you accuse him of something is part of assertive skills, and you have to learn to encourage that. Be a trusted adult. Very often, a child may not be able to say something to the parents, but if he's got a close bond to the parents, to the teachers, they often confide to the parent teachers anything, including sexual abuse and violence. Educate beyond the textbook, and teachers should attend workshops. And AHA and all of us are doing all this to teach them to learn the flag signs of depression, suicide, substance abuse, etc. And whenever they see such flag signs, they should involve parents, call them, tell them that this is what we are noticing in your child, and the child is encouraged to confide in the parents, and the parents should learn to take health from mental health professionals. The teachers must promote positive peer culture. They should set clear boundaries and consequences which the children can follow. Organizing awareness programs for peer pressure, high risk behavior, suicide prevention are extremely important. We have to teach them media literacy, demystifying ads and their negative implications on body image, and also teaching them safe online behavior. And of course, the teacher has to be a role model, practicing what she or he preaches. Similarly, parents, research all over the world has shown that those children who have a secure home, that there's no marital discord, he's not coming from a dysfunctional family, is less likely to go into risky behavior. Most of my patients who are having risky behavior, when I go into the family history, there is discordant parenting, there is marital problems, there are substance abuse or violence going at home, and such child is not happy or secure at home and looks for help or love or emotions outside home. And hence, if children have the security that I can speak anything to my parents, and my parents are always there to support me, not only when I'm right, but even when I commit mistakes or when I'm wrong, I can confide in my parents, and instead of punishing me and castigating me, my parents will, of course, not be happy about my behavior, but they will always be there to protect me. And you have to teach right and wrong, set clear boundaries, and know their world. You have to know their peers, you have to know their activities. Many tech savvy parents do not know what video games their children are playing, they do not know what sites they're visiting. And it's important to, at times, play the video games with the child to understand what games is the child playing. If it's good, you encourage them. If they're bad, you tell them the adverse consequences. You have to model healthy behavior, whether it is mental or physical lifestyle. As I already said, encourage assertiveness. I've already talked about screen time and media use. And it's very important to make adolescents responsible by involving them into family decisions. If you allow them to make decisions at home, even small or big, then the adolescents feel they're capable of decision making. Very often, the children are not allowed in any decision making in the home, and then you expect them to go out into the world and make decisions and resist peer pressure. And most important, parents have to be understood that if they see any flag signs of risky behavior, they must take professional help from psychologists or clinical psychologists or psychiatrists, and depending, and at least first go to your family physician or your primary pediatrician or adolescent expert who will guide you where to go. And lastly, we know that a safe community also helps adolescents from risky behavior and peer pressure. And in a community, if you have safe public places, if you have schools which are safe, where there's no bullying, there is no substance abuse, the children will feel secure in the school, and positive role models from their teachers. And we need to organize very regularly awareness drives and health camps. We have to encourage adolescents to have youth clubs and peer led initiatives so they learn the effect of positive peer pressure. Establishing supporting networks is extremely important. Having inclusive events where they involve all types of teenagers, including specially challenged teenagers, so they learn empathy and they don't discriminate between various peers. Collaborate with authorities who can provide such program, mobilize resources, and foster a culture of respect and accountability. So to end, every risk is good as long as it is for a good cause and contributes to a good life. Thank you so much for patient hearing.
Thank you, madam. Thank you. You are unstoppable and amazing, amazing. And we can see that so much of experience she carries. No doubt she's been awarded the IAP Maharashtra chapter also gave the Life Achievement Award. IAP is recognized as the Lady Pediatrician of the Millennium, and IMA the Woman Empowerment Award. Thank you so much, madam. It was amazing. You're unstoppable. We wish to see you more often on our platforms. Thank you.
Thank you. Thank you, Emma.
Thank you, ma'am, for the very informative talk. Thank you, ma'am. Our next session is about substance abuse in adolescents, the trends, risk factors, and prevention strategies. Dr. Atul Kanitkar will be chairing the session, and Sir is renowned child and adolescent care pediatrician from Nasik. Sir has a vast experience in conducting many workshops in parenting, in workshops for school and college students, as well as many other innovative workshops. Sir is also the author of the book, From Terrible to Terrific Teens. Over to you, sir. Sir, to unmute.
Yeah. So, first of all, I must thank the platform for keeping me in the chair. I won't take much time, but the previous talk was phenomenal. Uh, I know Madam for last so many years, so being a good teacher and always type of upgrading herself. So now our today's this session substance abuse speaker is Dr. Vivek Benegal. So he is a different type of person with a 21 pages CV, and basically I am not the person who can introduce him, but he's been given so many credentials for his research, studies, publications, and all that. Without wasting any time, I would like to allow Sir to give his talk. So over to you, Vivek Benegal, sir.
Thank you. Let me just see whether I can share my.
Make it full screen.
You can.
Yeah, just a minute. Let me. I'm trying to. Yeah. Okay. Thank you so much for inviting me to talk. I have been listening very attentively to Professor Swati Bhave, and before that, I've also listened to the other two lectures. I think all three of you have done most of the work that I was supposed to do. So what I will try and focus on today is some of the learning that we have had, especially from this particular research project. We have this neurodevelopmental cohort in India, which is one of the largest neurodevelopmental cohorts in the world, and we've been actually tracking how human brains grow and how humans acquire psychological skills and what creates vulnerability and resilience for psychological problems, psychiatric problems later. When Professor Jason talked to me and asked me to talk about the trends, risk factors, and preventive strategies in in 20 minutes, I felt that it was a very high risk activity to undertake, but I still felt that, you know, I should give it a little bit of a try, especially since you are all talking about safety, self-harm, and violence. Now, let us try and look at addiction in the larger terms of the theme of the conference. But to start with, let me assert that addiction is very much a pediatric disorder. And 9 out of 10 people with an addiction started drinking or using drugs before they were 16 or 17 years old. And the earlier you start, the greater the problem. This particular graph that I have is actually the quantity frequency measured in adult years based on when people started using alcohol. So as you can see, children who started at around between 10 to 15 had the highest use as an adult in terms of quantity and frequency of alcohol. Now, when we talk of the topics that we are talking of today, you would realize that these are intersecting domains with very broad overlaps. And most importantly, we need to realize and consider that most of these behaviors that we are talking about are very specific to, are very peculiar to adolescents. I mean, if you look at common adolescent behaviors, as Dr. Swati mentioned so well, that adolescents are much more impulsive than children. They have greater motivational persistence. They start out with a lot of enthusiasm. Halfway through, they tend to, lose their focus or their interest. They have greater emotional reactivity. They have difficulties in emotional recognition, which makes them very, very sensitive to rejection and, dysphoria related to rejection. They have greater threat perception and tend to slip much faster into anxiety and depression. And they are very, very, prone to going after high reward activities. So adolescent behaviors are not necessarily bad. They are developmentally and evolutionarily significant. They are high risk, high gain behaviors. And these are things that adolescents need to do to be able to become successful adults. If they were not, example, we talked about peer pressure in the last session. If we were not able to live with our peers and we lived in our parents' homes, we would never be able to, as adults, go out and make our way in the world. If we were not impulsive and we learned to take some high-risk decisions, we would never be able to take part in the adult world. However, what we also know is that some adolescents have a little bit more and just don't grow out of these behaviors, and a few actually get worse and develop problems. They can be homotypic, that is the same type of behaviors that they had difficulties with in the past, or they can be heterotypic, that different kinds of behaviors. So for example, children who have attention deficit hyperactivity disorder can later go on to develop addictive disorders, but they can also develop depression or psychotic behaviors, etc. Now, high-risk behaviors, youngsters with this kind of behaviors with reward deficit or threat perception are more likely to self-medicate with a particular group of behaviors or with a particular group of substances, all of which have one thing in common, that they increase activity in the reward circuit, that they give people a sense of reward. And because they tend to use this over and over again, they tend to develop early, repeated, recurrent use patterns. Now, what are we looking for as pediatricians or as psychiatrists? What are the things that we need to be aware of? There are some behaviors, some common vulnerabilities which are transdiagnostic. These are things which affect not only the kids who will go on to develop problems with substance use. These are the kids, these are the behaviors which are often found in children who will develop problems with, say, violence, self-harm, etc., etc., all the topics of today's discussion. And these are, number one, difficulties with cognitive control. Most important is the inability to sustain motivation. These are kids who start off with a lot of enthusiasm, but halfway through they lose interest. As the task gets difficult or as the task gets more longer or boring, they tend to give up. So despite the fact that they might be very creative, intelligent, they find that they are not able to live up to their goals. And over time, they decide that they're not worth it. This also sometimes comes with a lot of impulsivity, hyperactivity. Our classic picture of ADHD, attention deficit hyperactivity disorder, is hyperactivity. But believe me, by the time somebody becomes an adolescent, hyperactivity goes out. There's more fidgetiness, but this difficulty with motivation persists into adulthood. And this affects multiple areas of life. This also affects emotional discontrol, inability to actually control emotions. These are children who are, called mercurial, prone to episodic discontrol. What I'm saying is that they, of course, go flip-flop. They are liable to become 300% angry when they become angry, 600% sad when they become sad, last for a short time, but after they come back to normal, the problem is already done. They have already created some problem. These are also people who later on are very prone to developing mood disorders, episodic mood disorders. And so that is also something that needs to be kept in mind. So these go hand in glove. They also could have, the mood discontrol could also be an exaggerated threat perception. And this results in greater anxiety, greater depression, post-trauma stress, and even things like paranoia. The third group of behaviors which are seen in children who are at high risk for other problems is a difficulty in allocating emotional value or emotional valence. And this often results in difficulty in having empathy with other people, other children, difficulty putting themselves in somebody else's shoes, is literally. They also have this whole thing of reward deficit. They're more likely to get bored very easily. They have high sensation seeking. Now, this is obviously a gradation from mild to moderate to severe. But why do these happen? We know they happen and they occur because of variations in developmental trajectories, in ways that the brain develops, variations in functional brain networks, which then are responsible for variations in psychological abilities, the psychological abilities that we use day in and day out to deal with our daily environmental demands, as well as the acute challenges that sometimes the environment throws at us. And ultimately, these result in your sense of self, your sense of purpose, sense of self, etc., etc. Now, the reason why I'm talking about this is that I've spent almost a lifetime mapping these, and this is some data from our work which shows that, like the pediatricians have the normative curves of your growth curves of height, weight, head circumference, etc. We are now starting to develop these curves for functional connectivity, for gray matter and white, volume, etc. As well as we've now developed the functional curves of cognitive function, for Indian children from 6 to 30. So we find that children who deviate in their functional connectivity, we can predict that they also tend to deviate
in their cognitive domain curves. So deviations from normal connectivity curves are associated with deviations in cognitive curves. And deviations from the normal in connectivity curves are associated with behavioral problems and psychopathology later in life. Why am I talking about this? Because when we talk of difficulties in adolescence, I'm actually trying to take you further back. Because a lot of the things that are happening in adolescence have their origins very early on in life. How early on in life? Probably as far as the second trimester, when the brain is being sculpted. And so I would also like to draw your attention to the fact that we need to pull our interventions further back than we thought that we needed to. We've always focused on adolescence and what is happening to adolescents. But maybe we need to look further back. Now, we know that these variations in brain development occur as a result of dynamic ongoing interactions between the genome, that is inherited variations in genomic instructions to build the brain, which is called program-dependent development. And these are always being altered. The genomic program for brain development daily, day in and day out is being altered due to environmental influences or experiences across the lifetime, which is called experience-dependent development. Now, these could be problems that occur to the mother during pregnancy. It could be nutrition in childhood. It could be childhood adversities that a lot of you have talked about. It could be because of, and we've got data to show this, exposure to PM 2.5 in the atmosphere, or even gender disparity in society. All of these seem to have a role in sculpting the human brain. And the reason I say this is that, again, this has bearing on what we do in terms of intervention. And most importantly, these are mediated by multiple mechanisms which interface between the genome and the exposome. Importantly here, what we are finding, whether it is in heart disease or diabetes, or whether it is in Parkinson's, or whether it is in ADHD, we are finding very importantly that the stress inflammatory mechanisms, which ultimately affect microglial activation and consequent brain sculpting or reshaping, are very important mediators. And I'll come back to why I'm saying this, because this also has suggestions for how we need to plan interventions in the future. So stress inflammation is a common mechanism which links early stress exposure to brain sculpting. Now, stress causes not only inflammation, peripheral inflammation, but the peripheral inflammation is linked to central nervous system inflammation, and it affects the microglia whose job it is to basically sculpt the brain. Okay, and how do we know this? Because we have a lot of data showing, for example, that I'm showing this to you as an example, that maternal inflammation has significant impact on fetal brain development. So high sensitivity C-reactive protein in mothers at 24-week gestation is associated with high risk of ADHD in offspring at age 10. Now, this is scary. Even our research group is doing quite a lot of this work. I don't want to go into details here because we don't have that kind of time. But there are multiple causes of maternal inflammatory activation. They can be infective, neurotoxic, psychological stress, nutritional, etc. Consider this, that not only does individual stress spread to people around them, through words, body language, etc. This expands the cycle of stress. And this is something that, again, Dr. Swati was talking about, the fact that an individual child's stress spreads very quickly to other children, and it keeps, it becomes a cycle of stress, and this ultimately can escalate into widespread alarm or panic. And in today's day and age, social media is the convex lens, is the lens through which this is very severely expanded. And I believe that we shall have a talk about this later in the day. In today's internet age, stress does not even need direct human contact to spread. Stress signals and their long-term impact travels everywhere, almost instantly. So to come back to kids who have a difficulty in processing reward. Normally what happens in response to natural rewards, as you can see, there is an increase in reward signal, falls, and then goes back to normal reward threshold. There are some people, however, who, because they have a higher reward threshold, do not perceive or do not really perceive adequate reward from the normal rewards, as you can see in this cartoon. But when faced with supraphysiological rewards, for example, using alcohol, substances, all substances of abuse, bungee jumping, driving fast, fighting, stealing, what happens is that for the kids with a normal reward threshold, you get a very significant or supraphysiological reward. It's too much. So most times these kids will want to take it only once in a while. And so, they'll want to have a drink once in 3 months or 6 months or whatever. Whereas the others who have a higher reward threshold perceive this as okay, that's an interesting signal. That's an interesting thing, compared to the fact that they're not getting reward from anything else. This is something that they would like to follow up on, and they continue to use that. And anything that you do over and over and over again, whether it's your 5 times table or whether it's learning table tennis, you get better at it because your brain forms very stronger networks, and it leads to very strong learning, which leads to addictive behaviors. All known addictive drugs or behaviors activate the brain reward regions with sharp increases in the release of dopamine. And they provide much above par or overwhelming stimulus in persons with normal reward capacities, ensuring rare or occasional use, but they provide significant reward in persons with subpar reward, leading to regular repeated use. And that is the problem. We can also see drug abuse, to go back to my inflammation theme, as a xenobiotic, as a foreign object. Drugs or other insults are recognized as foreign molecules by the innate immune system, and they trigger a neuroinflammatory response. And ultimately, net, what happens is that the microglia, etc., further down the line, they respond to these drugs as if they are foreign molecules, and then they act. They create this inflammatory response, which in turn, sculpts our brain and makes changes which are long-lasting, which is why addictive disorders, addictive behaviors are long-lasting, are difficult to lose, and they certainly can't be got rid of by giving a lecture or sending to a rehab center, hoping that if the person does not use for 3 months or 6 months, he or she is going to forget. So some of those tactics do not work. So the way we try and understand addictive behaviors is that there are some people who have a vulnerability, a lifetime vulnerability, and this is because of poor psychological abilities, cognitive control, emotional recognition, reward dependence, etc., that I have talked about earlier. This makes them more prone to maladaptive behaviors. For example, they are more likely to experiment early. They have repeated failures. They're more likely to mix with deviant peer groups who all have similar problems and who've all been thrown out of the class. And they all have this propensity that they have increased reinforcement by dopamine enhancing substances or behaviors, whether it's alcohol or whether it's playing, some of these games or sitting and looking at reels on social media. This leads to early repeated use, and early repeated use causes neuroadaptation due to repeated exposure. I'm not going into details, but both the vulnerability and the neuroadaptation have cumulative consequences. Because of the behaviors from childhood, they've had failures, difficult psychosocial problems, etc. And because of the neuroadaptation, they've had consequences. So when you are looking at a youngster with addiction, you are looking at somebody who comes with these cumulative consequences, which is, withdrawal, dependence, medical problems, psychosocial problems, and lifelong problems because of the vulnerability. But you are also looking at, and which we don't appreciate enough, we are looking at a state of neuroadaptation, which has occurred in the brain because of repeated exposure, and you're looking at vulnerability. So, net, you have a triangle of concerns that one needs to keep in mind before you, for planning treatment strategy. Sorry, I am going the opposite way. So what do we do? I mean, I will end with 3 slides where I basically talk about the strategies which we need to keep in mind. I'm not going to go into details because the time is short, but there are 3 levels of strategies. One is indicated prevention, which is treatment strategies for adolescents who have already developed problems. And here, the first thing that one needs to do with a child or an adolescent is to engage in a particular treatment model. One needs to modify the motivation for change. Often people use a motivation interviewing style to get people to change their motivation, to alter their motivation. But one of the things that we found very useful is to use a technique called reframing, because most people who come in in a stuck state, they have asked the same questions and have got the same answers, and they cannot get out of this chakravyuha. And so you need to work with the child as well as the parents to work on an alternative explanatory model to set them off on a plan, but also to generate hope that there is a way out of this. And so you need to use this reframing. And one of the ways that we use reframing is this particular model that I've talked about, the fact that addiction is not necessarily because of the bottle or the phone or the game, etc. It is an epiphenomenon of an underlying, set of problems which the child has had for a long time, and because of which the child has had problems in school, has had problems at home, has had problems, with friends, etc. And when that hits the children as well as the adults, they say, "Oh, that is why this is happening." Then they are more likely to say, "Oh, you think this can be taken care of?" Said, "Yes, it can be, but you also need to deal with this substance use." And then they are happy to say, "Oh, that we'll also take care of. But if you help me with solving these problems which have bothered me from childhood, I am fully in it." And so this reframing is something that we use and use very successfully. What it also does is it makes sense. Sense making is a very important job of what we do as physicians, what we do as helpers, what we do as mentors. And so this process is very important, because unless you do it, you are you're working with somebody who's an adversary, who's been dragged in saying, "Oh, he's a drug addict." And as soon as the child comes and says, "No, I'm not a drug addict," and you are going and saying, no, but you use this, you do that, you do this. And so it's a fight which nobody wins. And well, that has bad consequences. The second thing that we need to do is deal with the cumulative consequences that I talked about. One often has somebody who comes in a crisis. You need to manage the crisis, whether it's a physical crisis or it's a legal, social crisis, etc. And this is for adults, we use this mnemonic: liver, lover, livelihood, law. I mean, the same thing applies to children with a little difference. Liver, which is physical problems; lover, which is problems with parents and with other interpersonal problems; livelihood, difficulties in school, college; law, sometimes getting in afoul of the law. And so these are crises that need to be handled. The third thing that needs to be done is to counter the neuroadaptation. The most important thing is to prevent relapse. Number one, by relieving withdrawal states. I'm not going to go into details. And prevent lapses from becoming relapse. You need to understand that, once addiction happens, once this learning happens, it's so hard-coded, it's not possible to suddenly wake up and say, okay, I'm going to stop doing this. Never happens, right? And if any of us as physicians expect that that will happen, we are in for a long course of therapeutic nihilism. We are going to say, hey, I can't do anything about this. The other thing that we need to do is to treat co-occurring problems, co-occurring medical problems, co-occurring psychological problems, etc. I'm not going to go into details. But the fourth thing that I place a lot of stress on, and our team at NIMHANS has, for the last 15 to 20 years, we've placed a lot of emphasis on, is that you need to address the vulnerability. Please understand that addiction does not occur in a vacuum. Please understand that a child who's slashing his wrists does not happen in a vacuum. Please understand that any of the high-risk behaviors that we are talking about do not occur in a vacuum, and their beginnings probably happen, from second trimester pregnancy onwards. And so we need to really understand what the transdiagnostic difficulties are, and we need to help provide skills, which Professor Bhave was talking about so eloquently. We also need to provide mentorship. Most of the children who come with difficulties have not had the benefit, although they've had parents, sometimes they've had helicopter parents, but they haven't had parenting or other mentors who have been consistently there for them, who have actually showed them the way to go ahead, etc. The other thing is that we need to look out for externalizing, internalizing temperaments and disorders. Sometimes you don't get disorders. You don't get ADHD. You don't get, conduct disorder. You don't get mood disorder. You don't get depressive disorder. You get subthreshold presentations. And those also are things that we need to look out for. Unfortunately, we psychiatrists have gone around trying to tell people that you need to look for the disorders. We give you screening pro forma saying, oh, look for this disorder, look for this disorder. Most of the kids that we will see do not have diagnosable disorders, but they have difficulties, they have distress, they have some deficits. The second group of people that we need to deal with is people who require selective prevention. These are adolescents who haven't started having a problem, but are at high risk, probably because they have a strong family history, probably because they come from lower socioeconomic status, probably because they are, left at home all by themselves, a lot of things that all the three speakers beforehand have talked about. And screening, brief intervention and referral to treatment is probably what is the most important thing to do here. And one screens for distress, difficulties in coping, etc. Look for subthreshold things, not necessarily diagnosis. Making sense for the adolescent, promoting skills for the adolescent, providing mentorship, like I said earlier, are things that one needs to be able to do for these adolescents. These blue zone strategies, I mean, I'm sure you've read about blue zone strategies for the elderly. Some of them are also very useful for growing brains, as they are for aging brains. And reducing exposure to high-risk behaviors is very, very important. I mean, while we are talking about substance use, let me also tell you that the latest difficulty that we have is young people and use of screen exposure and social media. Now, all of you are aware that this repeated social media hits, or the repeated hits that you get from electronic stimulus, is like an addiction, is stimulating your reward circuit so much that it actually creates the same neurobiological changes that alcohol and tobacco does. And so these are very, very important. And some colleagues of ours have actually looked at how early exposure to screen time increases risk for psychiatric disorders, for suicide, for violence, etc. In fact, this work was even quoted in the economic survey this year. And I think we really need to look at the whole spectrum of high-risk behaviors. Now, to go back to that cartoon that I was showing you, if stress and inflammation are such major players in this entire cycle of creating risk vulnerability for psychiatric disorders, including violence, including all the high-risk behaviors, including addiction, then these also raise very intriguing ideas for universal public health interventions. If we can reduce stress perception, we might be able to prevent or preempt some of these disorders happening, especially in the universal public health sense for children in the community. So, things like exercise, your sleep, eating, high nutrient foods instead of eating highly processed foods, less screen time, getting people to learn to socialize. These are things which have been noted, and there's been increasing recent literature on how they actually bring down inflammatory response, as well as make changes in brain structure and function. And so my last slide basically is about universal prevention, public health, preemptive and preventive strategies. In a nutshell, these are what the United Nations Sustainable Developmental Goals call for. So it needs to happen at 3 levels. Our evidence from all across labs in the world is very, very clear that a lot of the problems, and this is not for just brain disorders, but it's also for heart, lung, diabetes, etc., even cancer, that they start in utero. So maternal anti-inflammatory interventions, whether it's use of micronutrients, and here I would actually like to raise, because it's an audience of pediatricians, I'd like to raise the idea of using choline as part of your micronutrient supplementation, and omega fatty acids for the kids. Stress skills and protection from envirotoxins for the mothers, pregnant mothers, I think is a very, very important thing to do. Similarly, for the children, nutrition, parenting skills, improved school environments, socialization, teaching children to socialize with other children and other adults, which happens so little these days because children have no place to play. Playgrounds are being converted into concrete structures. The other group is, of course, children, older children and adolescents and young adults. Again, one needs to look at nutrition, trying to promote multi-nutrient foods versus highly processed foods, incorporate movement into day-to-day activity, social games rather than sitting and playing electronic games by themselves, reduce screen time, learning to deal with boredom. And that's something which is very, very difficult for young people today. To counter the impact of environmental adversities, schooling, enrichment of experiences, skills to foster abilities, and to develop a purpose in life. Now, these are soft things. 5 years ago, I wouldn't even be caught dead talking about these things, saying, it's too soft, it's soft science. But the science for this is actually, improving. Mentorship, like I said, and making sense is a very important skill that we should have, so that we could help adolescents. And of course, practically, we need to reduce availability and increase access to alternatives. So to summarize, the psychological capacities of adolescents are evolutionarily shaped to enable them to integrate with and adapt to the challenges of adulthood. However, they're also likely to lead to impulsivity, experimentation, independence, defiance of adult strictures, etc., which can lead them to high-risk behaviors. Some adolescents, due to variations in neurodevelopment, where stress inflammation mechanisms in response to environmental triggers have a major role, have greater difficulties and are at greater risk. Early repeated use leads to prolonged brain learning and long-standing difficult to change maladaptive behaviors linked to substance use, linked to use of addictive behaviors. Interventions need to occur at 3 levels: indicated prevention for adolescents who already have problems, selective interventions for adolescents at high risk, and universal community level public health measures. I will stop there. Thank you very much for a patient hearing.
Fantastic talk. Vivek, expect from you. Expect from you. You've done a great talk. It's lovely, huh? Atul, any comments?
Vivek, you really explained the pathophysiology and the management addiction so beautifully. Thank you so much. Learned a lot from your lecture.
Thank you.
Mind blowing, Dr. Vivek. Thank you.
Thank you. And so were you. Both of you.
No, Vivek,
An eye-opening talk. Very nice. Very nice.
Thank you, sir.
Thank you.
Excellent session, sir. And that too, you helped us in the last moment in such a short notice. Thank you so much, sir.
Expect it from Vivek. Vivek has done so much work on this area. Street children is something he's worked on. A lot of street children, he's done the brain networking of street children and found that they have a lot of problems with their brain, you know. They run away from home and they're on addicts and fuel. They petrol, you know, addiction is there. No? They sniff petrol and all that to get high. These things and all, he's worked a lot on it. He's done a lot of work. That's why I called him for this session. Expected it to be a great session and he done it. Thank you, Vivek.
Thank you.
Thank you, sir. We are running a bit short of time. Our chat is just flooded with thanks and congratulations for all the informative talk from all our former speakers. Thanks a lot. Now our next session will be about the disruptive disorders and pathways to vulnerability, context of psychiatric interventions in adolescents. To chair the session, I invite our own organizing chairperson, Dr. Jason Sayoni. Sir is a veterinary pediatrician. Sir is also the chief editor of both IAP Drug Formulary and Child India. He was the past vice president for South Zone. Over to you, sir.
Thank you so much for this. The sessions have been wonderful and all the speakers have done their job. And you're going to have an even better talk by Dr. Shekhar. He will talk disruptive behaviors and pathways to vulnerability, because disruptive behaviors, disorders like opposition different disorder and conduct disorder are characterized with difficulties in regulating emotions and behavior, often leading to aggression, defiance, and rule breaking. These disorders are, you know, this also starts from very young, you know, the child, like Vivek was talking about in prenatal time also you could have problems and, you know, responsive parenting, if you do ECD is something that we should all practice, because if you don't do responsive parenting, you don't understand the cues of children and you force feed children, but you're going to develop opposition-defined behavior later in life. So these are stresses, you know, stresses can definitely cause brain problems in children, and post-traumatic stress disorders are something, even giving IVs and giving an ICU admission could be a big problem for children who could have problems later in life. And to talk about all this and more, we have Dr. Shekhar Shadri. He's a child psychiatrist with over 40 years of experience in the field of child mental health. And as former senior professor in the Department of Child and Adolescent Psychiatry at NIMHANS, his work has extended beyond the clinical population of children to childcare institutions, service providers across the country, as well as Southeast Asia. He is a great person. His interests are in childhood trauma, gender and sexuality issues, and lifestyle education. We've learned a lot from him right from the age from when we started the childcare center. We had the book on life skills, which I had published. He was instrumental in helping us out with that, and he's been a great friend over the years. He's also extracurricular activities are excellent. He's good, including theater, developmental approaches, and mental health interventions. And he's also a good singer. I think he's an all-rounder. He's one of our best persons. You can't sometimes understand what he's talking sometimes because it goes over your head, but we're going to have a great session. Over to you, Shekhar, for this session.
Thank you, Jason. Friends, what I'm going to speak about in some ways is in continuity with what Dr. Bhave and Dr. Benegal have presented. With both with the Indian Academy of Pediatrics and with the Adolescent Health Academy, and also my association with iCancel and the Indian Child Protection Medical Professionals Network, I see in the IAP fraternity and family an increasing interest in social pediatrics. So I would like to predicate what I wish to share with you on an extreme manifestation of disruption. Vivek has spoken about substance use, about aggression, and that entire spectrum of what he described as externalizing disorders. I take you back, friends, to the Nirbhaya episode. And it is said of that 17-year-old in this infamous episode that his behavior or involvement was the most cruel of the lot. Is that the truth? We know now, because of our conversations with members of the judiciary who were involved in this particular case, that that is not the truth. It was a trial by media. The fact that he lived 80 kilometers out of Delhi in a family that had one mentally ill, untreated, dysfunctional parent, is that the truth? That he was going to school, he had a learning disability, he was hit by a teacher and he dropped out of school, is that the truth? That he shifted to Delhi to send money, which he earned from cleaning vessels initially in a roadside eatery, in regular contact with the family till 4 months before the Nirbhaya episode, to support a family with one dysfunctional parent and two younger sisters. Is that the truth? And then he was befriended by this group of people who ran the transport business. And somewhere, for lack of a better term, let's say the perversion of his soul took place and he got involved in this particular episode. Now, friends, the Juvenile Justice Act has two components: children in conflict with the law and children in need of care and protection. And the question I put to you is, where was the Juvenile Justice Act when this child was in need of care and protection? My submission, therefore, is that every child in conflict with law, in conflict with authority, engaging in disruptive behaviors, is, was, and continues to be a child in need of care and protection. Why was the Juvenile Justice Act 2015 changed? People say because of the Nirbhaya episode. Truth as that may be, true also the fact that we feel strongly about violence against women, there is a more awesome and awful truth that I would like to share with you. The Juvenile Justice Act, my friends, was changed because a teacher hit a child. The worst injustice that you can do to a disruptive child, a badly behaved child, a learning disabled child, an oppositional child, is to suspend him from school, because then you're ensuring that he is in contact with other school dropouts and then getting into what are called as the pathways of vulnerability. And therefore, the role of adverse childhood experiences and trauma in early childhood for the group of people who Vivek has described as vulnerable because of the entire lifespan aspects, including what happens to mothers during the prenatal period in pregnancy, and the kind of brain processes that are modulated by maternal stress is one issue. The last point I want to make in this regard is again in continuity with the points that Vivek made in terms of understanding disruptive behaviors, because neuroscience and neurodevelopment informing policy has been manifest in some of the work that we have done in the last 5 years. As you know, two of the major processes, which is synaptic pruning and myelination, very important for higher level social decision-making processes, which are involved in how decision-making goes awry, and then we get into processes that are disruptive in nature. We know that synaptic pruning occurs front to back and myelination occurs back to front, meaning that those parts of the nervous system that are involved in higher level processing and decision making are the last to develop. So maturity is not a birth date. That at 17 years, 364 days, you're stupid and immature. And that night you're having your birthday and a group of people are there. And as the clock strikes 12, 10, 9, 8, 7, and everybody sings happy birthday. And the next day you become automatically mature. Maturity is not a birth date. And this brain development actually continues till the age of 21, 22, 23, 24. And this aspect, when the law was changed, is what we recommended to the Honorable Supreme Court of the country. And in the Barun Chandra Thakur versus Master Bholu judgment of the Honorable Supreme Court, where this methodology of looking at children who come into conflict with law has been recommended, where robust psychosocial assessment and robust neuroscience must inform how we actually deal with the children that we seek to assist. Now, I want to take you through some of the issues to expand on this theme a little further. Now, if you look at the kind of disruptive behaviors, what Vivek described as a broad label as externalizing disorders, runaway behaviors, aggression, antisocial behaviors, substance use, and other high-risk behaviors, including conduct disorders, oppositional defiant disorder, and attention deficit hyperactivity disorders, and the attendant life skills deficits, whether they relate to negotiation, refusal skills, in context of addictive behaviors, or in problem-solving conflict resolution in the kind of situations that Dr. Bhave described. But if you really put this into pathways of vulnerability and the basis of integrating child protection and mental health as kind of the obligation and mandate of social pediatrics and those of us who are interested in adolescent health, here is something that you'd like to really look at. If you look at some of the underlying causes, emotional factors such as parental marital issues, domestic violence, physical and sexual abuse, alcohol dependence, in parents, punitive parenting, death loss experiences, and how they give rise to emotional dysregulation, both where anger, anxiety management are concerns, with the attendant attachment injuries and trauma experiences that occur. Now, this has been seen in very elegant fMRI studies where children exposed to chronic trauma and adverse childhood experiences, those parts of the brain that are involved in emotional dysregulation, particularly the amygdala, are affected, thereby leading to increased risk and problems as they sort of migrate from early childhood to middle childhood, early adolescence to later adolescence. If you add to that the kind of deprivation and neglect with lack of early stimulation and growth opportunities, you can see how that gives rise to developmental delays, learning issues, and poor acquisition of life skills. Then if you look at educational issues such as learning difficulties and poor academic performance and the kind of experiences that occur in school, either punishment or experiences of bullying and exclusion, as it occurred in the adolescent in the Nirbhaya case, and how that leads to school dropout, truancy, suspension, and then the movement into further pathways of vulnerability. This added to life skills deficit, poor problem solving, emotional regulation, and the kind of critical thinking that Dr. Swati alluded to when she spoke about the various mechanisms and response repertoire that is available to you when you're in situation of conflict or situation of stress. And if you don't have the necessary life skills, then you have limited ability to process and solve problems. And this results, therefore, in high-risk behaviors, disruptive behaviors. Add to that peer influences, aggression and rule breaking, which is reinforced in the context of the peer group. And then there is a gravitation towards joining these groups, which in fact reinforces their fragmented sense of self and identity. And if you cannot contend with peer pressure, assert yourself to say no, and then the possibility of engaging high-risk behaviors in keeping with peer group norms increases. Add to that substance abuse, be it either as experimentation or to cope with stress and difficult emotion and its gravitation towards more serious forms of use, leading then perhaps to dependence patterns. Then, of course, in vulnerable children, there is this added social problem of child labor, which includes separation from the family and exploitative conditions of work and poor remuneration. And these experiences of neglect and loss of attachment relationships, exposure to older adolescents and adults who might coerce and engage in antisocial behaviors themselves and act as role models. Needless to say, many of these kids have pre-existing neurodevelopmental issues and mental health problems, which Vivek has alluded to, attention deficit hyperactivity, anxiety and depression, which only adds to the social skills and self-esteem deficits and poor decision-making abilities that these kids have. And all these actually increase the risks and the psychosocial issues and mental health problems that these children face. So what I submit to you is, as practicing pediatricians interested both in child mental health as well as in adolescent issues, the whole revolving door syndrome, where there is a lack of quality mental health interventions, leading to an escalation of mental health problems, perhaps a negative response from caregivers and service providers, further exacerbating mental health problems, leading to heightened protection risks, and then mental health problems. And the whole cycle repeats, putting these children who are in difficult circumstances, in vulnerable circumstances, presenting with disruptive issues to come into a situation where they engage in further and further disruptive behaviors. Now, I would like to take you to the last part of what I started with, and this is, like I said, in such remarkable continuity with what Dr. Bhave presented and what Vivek presented as well. This whole difference between the adolescent brain and the adult brain. Now, if you look at this neuroscience perspective, and if you look at socio-emotional systems and cognitive control systems, what happens is that the social-emotional systems that lead to increased reward seeking and instant gratification actually develop faster than the cognitive control systems. So adolescents have greater impulsivity and susceptibility to peer influence, whereas cognitive control systems, which regulate emotional impulses and influence social judgment and decision making, developed far slower. But like I said, even up to the age of 25. And as cognitive control systems develop, adolescents become less impulsive and are better able to make appropriate social judgments and decisions. So, if you look at this neuroscience perspective, if you look at disruptive behaviors, risky behaviors, high risk behaviors such as sexual decision making or substance use or violence, the interaction between the changes in these two neurobiological systems, the socio-emotional functioning and cognitive control, risk taking actually increases from childhood to adolescence and again declines between adolescence and adulthood due to changes in the brain's cognitive control systems that influence self-regulation mechanisms. And since adolescents are not fully mature, they tend to be predisposed to high-risk behaviors. And therefore, this transitional stage in which the acquisition of skills that control and mitigate behaviors that become disruptive become important. And if you look at children in conflict with authority, children in conflict with law, the combination of adolescent brain development and adverse childhood experiences, ACEs, which are risk factors for mental health problems, emotional abuse, physical abuse, neglect, violent treatments towards the mother, household substance use, household mental illness, parental separation, an incarcerated family member. This combination, as we know, there are a high prevalence of ACEs in children who come into conflict with authority, conflict with law, children who engage in disruptive behaviors. So the multiple types of ACEs should be considered as risk factors for a spectrum of disruption of violence-related outcomes during adolescence. Please mark the legends in red. The adolescent brain functioning plus higher ACEs lead to higher disruptive behaviors. Hence, disruptive behaviors coming into conflict with law, into conflict with authority, needs to be understood in terms of adverse childhood experiences and implications for the circumstances of why and how children become disruptive. Let's take a deep dive into this. There are cold cognitions and there are hot cognitions. Cold cognitions are working memory, the ability to suppress, stop actions that are inappropriate in a given context. They are used in situations that entail thinking and decision making in the absence of intense levels of emotion. So the presence of adult consultants, the absence of mentors that Vivek referred to, the absence of time pressures. So the mitigation of the dangers of impulsive decision making. And there are examples of this: voting, consent for medical procedures, choosing subjects in academics, and so on. Whereas mental processes which are emotionally charged in situations which are difficult, emotionally arousing, such as driving, consuming alcohol, and behaviors which are criminal in nature. So if you look at logical processes in decision making, making use of the types of information and different prioritization. Let's take some examples. Adolescents are more likely to engage in unprotected sex, not because they lack health information, but because the potential benefits of unprotected sex, spontaneity, heightened pleasure seeking are perceived to be greater than the potential health risks, such as pregnancy or infection. So in decision making, adolescents prioritize spontaneity and pleasure, whereas adults prioritize health problems or risk and select their information accordingly. So if you look at pathways to disruption, pathways to offense, this is what I submit to you, friends, as the context for intervention. So if you look at attachment issues, neglect and abuse, children who are reared in families where there are power-based aggressiveness, single parenting, and so on, these factors actually give rise to emotional dysregulation and behavior problems such as violence, destructiveness, and so on, and a lack of empathy. And therefore, interventions that are focused on emotional regulation, on empathy building, become the focus and the context of intervention. If you look at educational factors such as learning issue and the impact that they have on the lack of motivation to continue education, on truancy and suspension and school dropouts and unstructured times, how, therefore, as practicing pediatricians, the kind of work that you do in school to recognize these kind of vulnerabilities and children who come from these kind of contexts to ensure through resource room, through school-based interventions, so that school retention becomes the focus, because the safest child for a child place for a child to be in is school. And like I said, the worst injustice that you can do to a learning disabled child, a badly behaved child, a disruptive child, is to suspend him. So how do we actually ensure retention? How do we work on life skills deficits, either because of lack of supervision or guidance, or because of primary deficit in skills that occur because of pre-existing attention deficit disorders, or the impact of life skills of adverse childhood experiences, that school programs that focus on universal interventions and looking at these life skills methodologies as part of the work that practicing pediatricians can do in schools to really address both internalizing and externalizing problems by taking the context in which they operate, such as peer pressure, such as conflict situations, such as arousal and attraction, such as a relationship breakdown, such as academic pressures, such as abuse experiences, so that the impact that life skills deficits have, such as excessive threat perception, problem-solving deficits, where they use aggressive forms of conflict resolution versus non-aggressive forms, and the kind of perceptions that they have about events, misinterpretation of events, overreading harmful intent in others, where outcomes are interpreted as intended or intentional. Similarly, if you remember what Dr. Bhave had pointed out, the inability to contend with peer pressure, particularly when you're marginalized or excluded and you come from a situation where you have self-esteem problems or anxiety, but you get into disruptive behavioral patterns in order to belong to a peer group and an identification that gives you a sense of peer norm groups and an elevation or an escalation of your self-esteem and experiences of identity. And how, therefore, through this process, you gravitate also towards substance use, and therefore the link between substance use and disruption, the link between substance use and offenses which are either disruptive or antisocial in nature, and finally culminating in them coming into conflict with authority and conflict with law. Needless to say, the number of children who come from adverse circumstances, who are, for example, trafficked for child labor, and the kind of work in social pediatrics that you can do other than your chamber practice or your hospital practice, to really look at city sectors and inner city ghetto-like areas and places where there's a gravitation of children from the lower socioeconomic strata who are sent away for work. They may come from Jharkhand or Orissa, but they are, for example, in Bangalore or in Trivandrum or in Mumbai or in Delhi. And to be able to work in some of these sectors so that children who are far away from their family and have little connect, as it is, they had adverse childhood experience, but they experience further neglect and loss of attachment relationship. Remember the Nirbhaya case, a very, very strong case in point. And finally, there are these mental health problems, attention deficit, hyperactivity disorder, conduct disorders, where rule breaking and disruptive behaviors, destruction, truancy are part of the symptomatology of the disorder itself, and how, therefore, there's a gravitation towards conflict with authority. And how some of these, if you look at neurodevelopment problems like ADHD, and the kind of impact it has on social skills deficits and decision making and sensation seeking, how recognition and treatment of this, in addition to internalizing problems which can actually manifest as disruptive behaviors. So the actual problem is anxiety or depression with attendant self-esteem problems, but they gravitate towards substance use in order to reduce the stress that they feel. And if you add to that the adverse childhood experiences and substance use and how that leads to dysregulation and to disruptive behaviors. So this chain of events is important to actually keep in mind. So to summarize, essentially, the pathways to vulnerability where disruptive behaviors are concerned range these 6 or 7 factors that I've spoken to you about. And in a given instance where an adolescent may be brought to you with a presenting problem of disruptive behaviors, how do you look at the background and the history, the life history of this particular adolescent, to look at which vulnerability factors or a combination factors actually plays out in that individual child in front of you in the consultation chamber, to then have a frame of reference where your interventions attend to every factor that has contributed to the end expression, which is the disruptive behavior, rather than focusing only on the behavior through what are conventional approaches, which are well-meaning, but they may not be effective, but because they do not address and attend to the background issue that has actually contributed to the disruptive behaviors. So a lot of these interventions that I speak about are present in the website of the initiative that I was hitherto running. I'm taking the liberty to put the link of that website on chat. Please do have a look at it. And it's www.nimhanschildprotect.in. A lot of these interventions are given in detail in our manual, 2 manuals. We have one on socio-emotional skills and one on gender, sexuality, and relationships, where a lot of the work that you can do either in chamber practice or in social spaces that you work in as part of your interest and obligation in social pediatrics. The manual is written in a way that are implementable on the field. It's a how to do it manual. It's very easy to actually adapt to some of the issues which are part of the disruptive disorders paradigm. So how to deal, so there are modules on anger, there are modules on conflict resolution, there are modules on aggression, and so on. There are modules on empathy building. So please do have a look at it. And thank you very much for this opportunity, for this remarkable event that has been organized by the organizers. Over to you.
Thank you, Shekhar. Lovely talk, as usual. But it's difficult to do all this right from the beginning. How do you start this off? We're doing ECT, we're doing the early childhood development program as a module for workshops for all pediatricians, trying to tell them how to stimulate children to get normal development and how do you respond to parenting and all that. But how effective is it going to be to prevent all these disruptions that could occur over time?
I'd like to respond to that, Jason, with a very simple paradigm. I believe also, Shalini, the modules are present in the website. that I put on chat. Do have a look at it, Shalini Yadav. If you look at the modified social stress model, the modified social stress model, which Vivek and I had used many years earlier in the work that Jason alluded to, in the work that we did on with street children, and of course. A lot of the work that Vivek did thereafter has gone beyond that to look at some of these very robust paradigms using a life cycle approach to look at early vulnerabilities so that you don't wait for disruptive behaviors to actually take place, and interventions are done when you identify high risk children very early in their lives. But I'd like to go back to that model because in some of the experiences that we had in its implementation, there was a very stark outcome which I'd like to share with you. The modified social justice model merely stated that the risk of substance use, the risk of disruption, the risk of anything is equal to distress or stress plus normalization plus effect divided by coping plus resources, plus support plus resources. Distress and stress are self-explanatory. The higher the stress, the higher the distress. Normalization is the extent to which disruption, drug taking, is part of the subculture that adolescents belong to. Effect is the effect that substance use, for example, has on giving a high or reducing stress. Support is your social networks. Who do you go to in your trouble? How extensive is your support system, your social network, your supportive networks? Coping is the resilience coping styles that you have, conflict resolution. Are you equipped with non-aggressive forms of conflict resolution? And resources are basically information resources, health resources, educational resources, entertainment resources, and so on. So the higher the numerator and the lower the denominator, the higher is the risk. Now, here is the thing. Just take one of these six, just take entertainment, just take resources, and in that, just take entertainment resources. It makes the difference, my friends, between that child who took 15 doses, the 15th of which was contaminated and died, and this child who took 14. He was not abstinent, but he survived because he was in your shelter watching a movie that was shown as part of the entertainment package once a week. All I'm saying is it makes the difference between life and death. So in any community-based work, and that was indeed the slide that Vivek ended with when he spoke about community-wide approaches. When you look at social approaches or public mental health approaches or public health approaches to mitigation of problems that we're dealing with where adolescents and children are concerned, the use of these kind of models are very stark in the kind of insights that they give us about how sometimes very simple and elegant interventions, like I said, can make the difference between life and death. That's my response, Jason.
Thank you, Dr. Shekhar. Any other comments? Anybody? Thank you, Shekhar, for this lovely talk as usual. I think a lot of us are trying our best, but I don't know if we're doing our bit. We're trying our best, but I don't know if we're doing our bit. That's something. In disability, we're doing a lot of stuff there, but I don't know whether we're doing the right things by reducing stress for these children, by telling them to go to NIOS and reduce their stress because they come crying because they can't cope. Tell them to reduce stress and prevent them from, and to find their strengths and do what they are good at instead of hopping on studies. That's something that helps them to cope. I don't know if that's a method of you could use. I mean, you work on strengths and prevent them from getting depressed because they're doing things that they can't do well.
Strength-based approaches have also been recommended. Sometimes there is so much of focus on addressing limitations and pathology. Remember again what Vivek said about subthreshold. A lot of the kids that we deal with do not necessarily have diagnosable conditions, and therefore if we do not look only at limitations of pathology and behaviors, and actually look at context and look at how kids actually process the experiences that they have gone through, and as Jason pointed out, look at interventions which are more strength-based rather than focusing on minimizing limitations or addressing pathology or addressing symptoms. So we not that symptoms and then limitations are not important. That's not the point I'm making, but I'm just saying that in a lot of community-based approaches, a strength-based approach to actually handling adolescent problems are very effective. And I think Jason makes a very important point. If you look at how adolescents perceive their identity, and if a lot of discussion is around the problems they have created and their limitations and how they are a problem, as opposed to looking at adolescents as assets, as social assets, and as national assets. So how does an adolescent perceive himself or herself? What is the central core of their narrative regarding their identity? And then, can we add in the work that we do? Can we look at some of the gifts and assets they have, and build on that, and build a communication and conversation and a counseling context that actually embellishes and enhances that point of view. It makes them visualize themselves. So it's really a question of, when you're working with an adolescent, what do you appeal to? No, you cannot be appealing to an adolescent as an unreasonable person. And if your approach is to say, listen, let's be reasonable about this, what you're saying is, I basically believe you're unreasonable. Whereas so you can't be appealing to their unreason. You have to appeal to them as people who have the capacity and the intrinsic gift of reason. And that makes a lot of difference in the way that they respond, therefore, in counseling contexts. Thank you.
Thank you so much. Thank you. Is any other topic we'll discuss with you later. Thank you so much, Dr. Shekhar.
Thank you very much.
Lovely talk.
Thank you.
Thank you, sir. Our next speaker is Dr. MKC Nair, sir. Sir will be discussing about the sexual abuse and exploitation, recognizing the red flags and ensuring the safety. To chair the session, we have Dr. Geeta Patel. Madam is a past central chairperson AHA, and she is a consultant pediatrician who is also an adolescent health specialist working at Chaitanya Hospital, Bangalore, also at Manipal Hospital. Over to you, ma'am.
Thank you very much, Dr. Vidhu. I know that we are running short of the time, so I'm going to talk everything briefly. And thank you very much at the outset. Let me thank IAP Kerala, AHA Kerala, IAP Kochi. Especially, I should thank Dr. Jason Unni sir, Dr. Deepa Janardhan, and Vidhu Ashok. This is such an important conference with a theme which is very relevant for the present circumstances. So far, we have heard so many mesmerizing, informative talks. I'm very sure, Dr. Deepa, we are going to have a recorded session because we need to listen this quite a number of times to understand few more things, and it will enlighten on all the topics because it is a great treasure for us. So, and the topic which MKC sir is going to discuss, sexual abuse and exploitation. Definitely recognizing the red flags, creating the environment of trust, and knowing the legal safeguards are very essential to prevent sexual abuse and exploitation. Let me be very frank that it's a great honor for me to chair this session. Dr. MKC sir is a mentor and guide to many. He may not be direct teacher to me, but I have learned from his talks, his books, his many guidelines, and his passion to help to the adolescent health. And apart from that, neurodevelopment also of the children. So, sir, I'm going to introduce to him. I think there are many things to talk, but I'm going to just briefly introduce to him. He's a director of NIM Spectrum Child Development Research Center. He's a founder director of CDC Kerala, all of you know. He's an emeritus professor in developmental and behavioral pediatrics, CDC Kerala. He was a formerly vice chancellor and emeritus professor research, Kerala University of Health Sciences. And he is the only one who was a national president for IAP in 2004 and he was a president for NNF in 2011 and 12. And India claimed, that is the International Clinical Epidemiology Network, he was a president. He has, to his credit, many research publications nationally, internationally. He has contributed, written books, author, editor. He has written many chapters in undergraduate textbooks. He is a member of governing body of Nurullah Islam Center for Higher Education, Tamil Nadu, Child Developmental Center, Thiruvananthapuram, Kerala, National Institute for Physical Medicine and
Yeah, leave,
Rehabilitation.
madam, leave it, leave all that.
Finish, sir. Thank you very much.
Very little time, so leave it.
Thank you, sir. Thank you, sir. Over to MKC, sir. It's a ritual to introduce a great towering personality, and I should not fail in that, sir. Thank you very much, sir.
Okay. Oh, sorry. Got into trouble.
This is a...
No, there's some I have done it, so now it has got confused. Twice it has come. Shall I get in again?
Yes, sir. I think you have to leave.
Yes, the full screen, if you make, will it change, sir?
No, I think I had done once, so now it has got into trouble.
Okay, sir.
So you removed it, na? What I got it. Now everything is. Shall I start again? I think.
Yes, sir. Yes, sir. You should share again, I think so.
There is a problem.
Deepa, have you got the slides?
No, okay. This side is there. No, it's not there. I sent her, but she didn't get it. Okay. Now, I stopped. Now let me try again. Some problem with that. Oh, can you go to the next person? I'll sort it out. Madam, go to the next person. I'll sort it out then.
Dr. Deepa?
Yeah.
Yeah.
Okay. No
Go to the next person. I'll sort it out.
Yes, sir. Newton. Okay, so sir is ready, no, sir. Okay, sir. I will just go on.
Well, it's taking time.
Newton, sir, is it okay, sir?
Let's not waste time. You go to the
Okay,
next.
no problem.
Okay.
Shamik Ghosh, sir, is there. Yeah.
A slight change. We are going to our next session, which is on ragging, bullying, and gang formation. To chair the session, I invite Dr. Shamik Ghosh. Sir is a well-known pediatrician working in Manipal Hospital, Kolkata, with special interest in community pediatrics and adolescent health. Sir has received various awards, including the prestigious Provincial Pioneer Pediatrician Award. Over to you, sir.
A very good evening to everyone who has been so patiently listening to some pearls of wisdom today. And thank you, IAP Kerala, IAP Cochin, and AHA Kerala for having put all of us into this classroom. Something like what Dr. Geeta Patil mentioned, which has to be gone over repeatedly so that we can capture the essence of all these teachings for today. So Dr. Newton Louis is somebody whom we have all admired for his deep dedication, his excellent sincerity towards the cause of adolescent health. He's somebody who researches every topic that he wants to present. I personally have been in complete awe of this personality. I've listened to his talks with all sincerity, sir. And today I will request you to please proceed with talking about certain deviations in human behavior, the pathophysiology of which was so excellently touched upon by Dr. Sheshadri and Dr. Vivek Benegal, Professor Swati Bhave, and the others. Over to you, Dr. Newton Louis.
Yes, let me try to share the screen. I hope I won't have problems. Don't tell me, I'm also having problems. Now, Deepa, can you just do it? Oh, she's
Screen
not
share, sir.
around. Can you just share?
Share,
Otherwise,
sir.
I'll be
Okay,
able to
1
figure
minute,
out.
sir. 1 minute, sir.
Is it visible, sir?
Yes.
Is it visible?
Yes.
Yeah, I think so. We are fine.
Yeah, and you can hear me, I suppose?
Yeah.
Yeah.
Yes, sir.
So, okay. So basically, I'm talking about adolescent violence. That's a very vast topic. So I decided to limit myself. This is, after all these heavy, complicated talks, you would hear a very simple talk. I've decided that adolescent violence is too vast a topic. I'm going to focus on ragging and bullying, both of which are typical adolescent violent behaviors, and not talk too much about the other pathological forms. I will try to mention adolescent gangs, and I will not try to avoid mentioning social and political adolescent gangs that we see in our country, which are both adolescent and adult oriented, and dating violence, things like that, because the topic is too vast. So basically, the adolescent violence. Basically, we believe that the popular view is that adolescent violence is increasing steadily, and we blame this on the increasing substance abuse in school, glorification of violence in the movies, and increasingly permissive culture at home where parents don't attempt to feel unable to discipline their own children, and the inability of teachers to discipline their students, because now we are very strict about they are not caning the students. The truth is, we just don't know. There's very little research on this topic. We do not know whether violence is increasing or decreasing. We have no idea about the prevalence of this disease, of this problem. What is the etiology, and what are the management solutions? Next slide, please. Next slide. Not working.
Isn't it working, Deepa?
Oh. Okay.
Oh. Then shall I try to share? Deepa, is it okay? I'll try to share.
Yes, Vidhu, please.
Anyway, first time I'll start by talking about bullying, a typical adolescent problem of children and adolescents. Not that much of a problem in adults. Bullying. It's a very common problem. There was a study done in urban schools, 6 urban schools of Bangalore and Bombay, good schools, and it was found that 1/3 of them were complaining of fear. Yeah, it's come. The slide has come.
Yeah, it's come, Vidhu. You can put it full screen.
Yeah, next slide, please. Next. Yeah, so bullying, next, previous slide, please. Yeah, so bullying, there are various types. It can be physical bullying, which is what we generally think about. Physical bullying, beating someone, taking his possessions, destroying his possessions. Verbal bullying, name calling, threatening, insulting, sexual comments, and social bullying, embarrassing someone in public, creating rumors about him, excluding him from your group. All types of bullying are very common. In a study from urban schools, 6 urban schools in Bangalore and Delhi, it was found that 1/3 of the students had complained that they had experienced in the last 1 year, adolescents in high school. 1/3 had experienced physical bullying, half had experienced verbal bullying, and 1/4 had experienced social bullying. The only difference that was found was that males tend to have much more of physical bullying, and females are more likely to indulge in social bullying. Next, please. Yeah, the preferred victim, because adolescents are very much concerned about conformity, pure conformity. So anyone who seems to be different, a different caste, a religious minority, or he just looks different because he's obese or short or wears glasses or something, that is enough for him to be considered to become a victim. Also, because the bully is somebody who wants to show his power to others, demonstrate his power, he also feels happier victimizing those who are look weak, intellectually less competent, so physical disability, somebody who has epilepsy, somebody who has some sort of weakness, he is more fond of bullying them. Next, please. Yeah, and only 20% of victims actually complain about it to adults. The reason being that most of them are ashamed to tell the adults about it. They are adolescents. They want to be independent. They want to be free of adult influence. They feel, even young children feel that we should not complain. They want to believe that they have the capacity to handle it on their own. Especially this applies to adolescents rather than smaller children. And then they fear rejection. If I complain about this, not only my friends will say that I'm a tattler, but also the bullies will all get together and bully me very severely. And that fear is often justified because the adults, the parents, the teachers do not take care of the bully properly. Next, please. Yeah, so there is sometimes obvious evidence of being bullied by such as unexplained injuries or torn clothes or lost property and textbooks. But most of the time, you don't find any obvious evidence of bullying. What you do see is depression, anxiety, fear of going to school, not interested in studies, declining grades, avoiding peers, avoiding social situations. So unless there is a high index of suspicion, which was mentioned earlier, we do not realize that this type of violence is taking place. Next. Yeah, but why do children bully in the first place? There are a variety of reasons. There may be personal factors like this. The bully is often a person with low self-esteem and he's bullying in order to boost his ego. Low social skills. He doesn't know how to become friendly with others. Depressed, antisocial personality, substance use is a very strong push for bullying because they lose their self-control. Peer factors like they have been bullied earlier. Family factors like they have an elder brother who bullies them, or their father himself is a very authoritarian person and a very severe punishment or neglectful parenting. Poverty is a general stress for for everybody in the family. And social factors. In a society which glorifies violence, you see violence in this community. We approve of policemen who physically assault, brutally assault criminals, and even suspected criminals, even before they are proven to be criminals. They are bullied, and we think that that's good. We see in all our movies, even Malayalam movies, any type of movies, you see in Hindi movies everywhere, the hero is often a vigilante. I've seen some Tamil movies recently. Vigilante. He takes the law in his own hands to solve problems. He uses violence to solve problems. So we encourage and glorify violence. We experience a lot of violence in our community. Teachers are permitted, or at least they were in the past, to use the cane fantastically for the slightest deviation. Parents used to thrash their children in the past, though fortunately, parental and teacher violence, school adult violence towards children is on the downtrend, I believe. So there are lots of factors why the children bully. Now, this leads us to one uncomfortable solution. These children are bullying others because they are not suffering. They themselves are suffering and they're trying to get rid of their suffering by causing suffering to others. So they are both victims and bullies at the same time. This does not mean that we should not control them. A bully must be stopped. He must be controlled. He must not be allowed to bully others. But once that is done, we also have a certain responsibility to find out why that child, how the child became a bully, and are there situations we can't get rid of poverty, but frequently there are some background situations where we can help with their life skills, abilities, and with some problems, maybe with studies or whatever, we can help them. We should keep that in the background once their bullying is controlled. Next slide, please. Next slide.
Yes, sir. 1 second. It got stuck. I think I'll just see.
I'm not sure what's happening.
I will pause and share again, I think.
Oh my God. Or just go on to this, these small slides also is good enough. Yeah.
So is this the next slide, no, sir?
Yeah, it's okay. You are.
Okay. Now it's.
Okay. Now, counseling the child who was bullied. That's the most important thing here. First, we have to ensure that they are safe from bullying from this bully or from his friends. And then we have to inquire what happened, find out in detail exactly what happened, how it happened. And even he will often feel that he asked for it. He could have acted in a different way. He got in trouble because it is his own fault. He feels guilty frequently. He's a victim mentally, not just physically. We have to clarify that whatever happened, he is a victim of bullying. He is not the cause for bullying. He did not ask for it. And sometimes they need treatment with a psychiatrist or psychologist. So let me conclude this session on bullying by saying that everyone connected to that child has a role in it. The parents, the teachers, the schools, and also peer support. There has to be all-round viewpoint, all-round attitude that bullying is wrong. Right. Now let's go to ragging. Again, problems?
Yes, sir. I will just stop and share again. Then it will work, I think. Sir.
No. So, okay, ragging. Now, this is typical, now, unlike what I mentioned about bullying, all the information that I got about bullying is from other countries, very little from India, nothing worth talking about from India. Ragging, we have excellent evidence on ragging, excellent information on ragging, because the Supreme Court mandated a study, a proper detailed study on ragging in India about 10 years back. And it was a 3-year study, and Dr. Shekhar Sheshadri was one of the main investigators of that study. Okay, so we have lots of solid evidence from India. The next slide. Just that's good enough. Now, it's obviously most prevalent. We know this, that it is most prevalent in engineering and medical colleges, especially in hostels, especially in males. Now, newspaper reports themselves are frightening. They say that over a 7-year period, before doing the study, they found that 71 deaths from ragging reported in English newspapers alone, 81 cases of permanent disability, and 128 cases of sexual abuse in the name of ragging. And this obviously just the tip of the iceberg. So the situation is terrible. Next, please. And there is always justification for it. Oh, these children have been, we are a top medical college, and these fellows have just been admitted into this medical college. We have to initiate them into this exclusive club. That's where we are ragging them. It is a part of our institutional tradition. It is, and also it's necessary. They all got swollen egos. They come into a good institution. We have to deflate their egos. What for? I don't know. And the stupidest of all reasons of all so-called justification is that ragging will create strong bonds of friendship between the person who is ragging and the person who was ragged. There's only one actual reason, and that is, I have been ragged in the past. Now it's my turn to rag in the future. I'm going to cause suffering not to those who rag me, but to somebody else in society. That is the only actual justification for ragging. Next, please. Yeah. And there are also institutional and societal factors for all this. The management should not encourage ragging, but the management is often doctors and MBA and all people who have themselves been ragged when they were students. So they may accept ragging as a beneficial tradition. They may ignore it, or they just can't be bothered about it. They just can't be bothered about it. And like I mentioned earlier, our society accepts all form of violence to maintain discipline. And the seniors say that we are maintaining discipline with these juniors. Next. Yeah. Then there is something called mild ragging. It's very mild. You just you have to call the seniors sir when you see them. You shouldn't look directly in their face. You should obey whatever they say, whatever stupid thing they say. You have to obey it immediately. They'll ask you to do something silly and you must do it immediately. They'll make you do some work, copy their notes, wash their clothes, etc. Whatever they say, do it immediately. Mild ragging, it's all benign. Yes, it's theoretically benign, but the psychological trauma, you're humiliating an adolescent who's at a very hyper emotional and hypersensitive situation. You're humiliating him. He has come and achieved a great achievement. He's joined a medical college. His great dream is satisfied, and that's when you shatter him and put him by ragging, and you say that you're doing something good for him. Okay, the psychological trauma is not mild at all. Next, please. So there are other forms of ragging also. This so-called manly ragging. There is basically adolescents are sexual beasts, always sexual. So at least among males, they make you make abusive statements about your mother and your sisters, also weird statements. They strip the guys naked. They make them stand in all sorts of funny positions, enact sexual scenes, tell a sexual story, watch pornography, masturbate, all this, and they get pleasure out of it. It's weird. Okay, manly ragging they call it. And then there's something called severe ragging. Severe ragging is basically a guy who was in school a bully, and somehow, in spite of it being a horrible bully, he managed to get into medical college in the future. And now, when he was a school bully, everybody was against him. Now he is blessed. He's got a chance to rag, to be as much of a bully as he wants to, and nobody is going to criticize him because everybody else is practicing a milder form of bullying. So he can torture his victims as much as he wants. Sexual assault, including sodomy, demanding money, forcing them to consume alcohol, forcing them to buy alcohol for him, and so on. Next, please. The psychological effects of ragging are very obvious. Lots of children of these adolescents underperform in their first year. They have no interest in studies. They feel depressed. They feel anxious. They feel upset. And they have loss of self-esteem, and they have very impaired relationships with their seniors. Many of them, especially with all those seniors who were severe raggers. That is obvious. Throughout the year, the severe raggers will have a lot of enemies. However, this is only initially. Later, what do they say? After the ragging is over, during the ragging, nobody enjoys it. But the moment the ragging is over, half of them will suddenly become self-unaware and say, "Oh, initially we didn't much care for it, but later I thought it was quite fun. This mild ragging is really humorous. I want to be a good humorous ragger in the future." They all enjoy it. Why? Because they have to justify it. It's not just the Stockholm syndrome. It's not the Stockholm syndrome. It's basically, I want to rag. Therefore, I have to justify the ragging. So I will say, I will deliberately form friendships with all those other mild raggers at least. I will boast about how I enjoy the ragging. I will talk about the funny aspects of ragging and all that. And I will say that now I'm more confident and more of an adult than an adolescent because of the ragging. It's all fooling yourself because you want to rag for the next 4 years. Next, please. And unfortunately, there is a ragging helpline. It's put there on the boards all over the place, but very few complain in the ragging helpline, and only 1% complete their complaint for a very obvious reason. And somewhere in the beginning itself, they ask, "Okay, what is your name?" And they stop there and cut it out, because if they tell their name, what is going to happen is they are going to a complaint will be set in, and the college authorities will come to know about it and take action. Once the college authorities come to know about it, they're all against this guy because he's spoiling the reputation of our prestigious institution. So they are not going to cooperate with the boy. They're going to be angry with the boy who gave a complaint. And the seniors will be caught and asked, "Did you do this?" And when they say yes, from that moment onwards, they'll be brutally ragged by all the seniors, and they'll be socially boycotted by their own class. So you can't trust the college authorities or the seniors or even your own batch. It's not worth giving a complaint. It's a very, very dangerous thing to do. Lots of persons who start with a complaint end up committing suicide. We've seen that in the papers. Next, please. Yeah. So one of the good things that this committee came up with all these 3 years detailed studies, they came up with a lot of recommendations after discussing with the juniors, seniors, management, etc., on what can be done at the institutional basis to prevent ragging. This is what the Supreme Court wanted them to do, and they came up with some good measures. They said, first of all, you should have welcome programs. You want an initiation? Okay, have it as a big welcome program. And it's not just the juniors. There must be the juniors, the seniors, the teachers, the management. Everybody should be involved. And you have a big welcome program. The juniors should be asked, "Do you have any special talents? Come on, this is a chance for you to demonstrate, sing, dance, skit, whatever." So that is an initiation program done with their interest. That is what you want. Then orientation programs you can have, and during this as part of this program, they will be told that there is a zero tolerance to ragging and sexual harassment. Both freshers and seniors will be informed about it. They will have to sign affidavits, both juniors and seniors. And the seniors have to sign an affidavit saying that if I am caught ragging, I am liable to a police complaint and to be arrested by the police, and I am liable to be expulsion from the college. This has to be clearly mentioned. That has helped. Separate hostels for freshers and full-time wardens in those hostels, and student mentors, ample CCTVs in all the right locations. These things have helped. Someone was telling me recently that Manipal, in the good old days when Manipal was the only 30, 40 years ago, practically the only private medical college. In those days, because of too many people with too much of money, it was horrible for IT. Now, In the recent times, very recent times, they have been very strict on anti-ragging measures, and practically there is no ragging in Manipal now, is what I got the information from some friends. Next, please. And some more measures, this is the last slide on ragging. Some more measures that have been suggested by the ragging the committee, but not accepted yet, is that anonymous complaints should be permitted. That once a complaint is there, the police should take action within 24 hours. And that the person who is doing the ragging, his parents should be informed that there is a complaint against him, and that he is liable to arrest and to expulsion, both in case the complaint is found to be justified. Once the raggers know that the parent is involved, once it happens to one student, now the whole college will come to know about it. Once they come to know about it, these raggers, ragging will come down dramatically, is the belief of the anti-ragging, of the people who did the study. It is being implemented in 1 or 2 colleges, but it's not a routine, it's not a demand, there's no demand for it. Next, please. Yeah, so we'll just go and say a few words about gang violence. I was asked to. Is there a lot of basically, there's a lot of information about street gang violence in America, because it's a very common thing over there. Small town street violence, especially between whites and blacks and Hispanics and things like that. They form groups to protect our members from other races. So they form groups, and then they are very violent. There's a lot of it. So there's plenty of studies on the online about gang violence. 95% of it from the United States of America, a smattering from other developed countries, and practically zero from developing and developed countries. Next, please. These developed countries, it's all about racial and ethnic line. They usually are very formal about it. And adolescence, pure conformity. The gang will have its own name, badges, strict rules, to show our unity, and we will protect each other, we belong to each other, like that. And they often carry guns and knives. They often have fast bikes, so they're desperate drivers. They often take alcohol. All this is part of being a part of an adolescent gang. This does not seem to be, it is there in all the developed countries, not much studies done, but it is there in all the developed countries, wherever they studied it. It does not seem to be much there in the developing and underdeveloped countries. One of the reasons that I think could be the causes, about drugs. 20 years ago, when you talk about drugs, you're talking about marijuana and about prescription drugs like nitrazepam, buprenorphine, and things like that. Today, you're talking about drugs in India, we are talking about MDMA, LSD, etc. Why? Because nowadays there are lots of 25-year-olds who have done the engineering course, and they have too much money and too little responsibility. So once a society improves and has more cash, things change. Societies change. Here, these street gangs, they have guns, they have fast bikes, they have the money to buy alcohol and drink it regularly. Their attitude is totally different. So in developing countries and underdeveloped countries, not that we are virgin pure, but one simple thing is that we have less of money. The second thing is that we are much more parentally controlled societies with a very authoritarian parenting. We are in America, by 13 years, by 18 years, they have 100% freedom. By 13 years itself, they have a lot of freedom. So in such places, adolescents can easily go into street gangs. In our society, where there is a much more strict control, this kind of things are definitely much less. Now, I have come across 1 or 2 studies in India. Next, please. Next. There are mainly news reports about adolescent members being members of adult criminal gangs. And from China, I could find just one study, nothing worth talking about. There are school gangs, very rare reports that I could find. Like there was a report about 2022 in Prayagraj. From 5 schools, somebody decided to form gangs. From 5 schools, 3 gangs were formed. 3 gangs of totally around 200 students, some around 60, 70 each of them. For how they formed and why they formed, we don't know. And these gangs started fighting with each other. They started making crude bombs and throwing it at each other, throwing it into the schoolrooms, throwing it into the hostels, fighting with each other, physically fighting with each other. School gangs, and all 5 were reputed schools. Okay, all this kind of things happens where there is less discipline and in the reputed schools. Here also, Dr. Deepa Janardhan was telling me about a reputed school where again drug being the promoter of school violence. So these things are beginning, and drugs are going to increase, and financial situation is going to increase, and we are now beginning to have these problems. I think. Next, please. Yeah. We have another type of violence. Just last two slides. We have another type of violence here in Kerala, especially. More than 500 cases of violence in just 8 years linked to student political associations, organizations in Kerala. And we can't do anything about it because our political leaders of today are all former leaders of they are student organizations of the SFI, KSU, and ABVP. So what can we do about it? They support these student bodies and try to cover up on their corruption. It's only recently that the public has become very much upset about it because there have been too many incidents recently of student leaders torturing members of other parties. Student leaders are strong in of one party is very strong in one school. There they torture the students who belong to another party. They have assaulted teachers who gave them less internal marks. They have acted as moral police. They have garrowed and assaulted principals, and a principal resigned. When this kind of things happen in the newspapers, recently there have been so many incidents that now people are beginning to stand against, and parties are now beginning to realize that things have gone too far. Next, please. Of course, here I am not talking about the North India, other states. The student political gangs are probably less in school, but student, what do you call it? The social and caste-based gangs. There are stories about them in northern India, but we will not talk about it. It's too dangerous a topic to talk about, and there's no evidence at all. Okay, now remember that anybody who goes into, at least this is again American data. Anybody who goes into a gang is doomed. This is big trouble because they might, most of them remain in the gang only for 2 or 3 years and then they drop out. But by that time, it's too late. Just those 2 or 3 crucial years of adolescence, they are delinquents, disobedient at home, troublemakers in school. Frequently, some of them will drop out of school, and that can have permanent future damage. They're always fighting with each other gangs, and then they start fighting among themselves, and there's intimate partner violence, and this is going to carry over into the future. They have a very risky lifestyle, totally independent of adult influence. So late night parties, alcohol and drug use, this sexual promiscuity, rash driving, which can mean death, deformity, so pregnancy, alcohol addiction. Okay, long-term effects. And how do they finance all these things? By petty criminality, robbery, drug peddling. They are on the cusp of becoming lifetime criminals. So even if those who drop out very fast within a few years' time, many of them have lifelong physical trauma, emotional trauma, decreased studies, social problems, lots of problems. Next, please. Yeah. Preventing adolescent violence, this is an extremely simplified version. Dr. Vivek Benegal in his last slide gave a detailed analysis of what all we can possibly do to prevent adolescent violence at the level of the family, at the level of the community, at the level of the students, his peers, and in society. So this is irrelevant. Next, please. Next, please. Okay, thank you. Next slide. Next slide. Yeah, and this is a scene from the famous movie West Side. No more slides. From the famous movie West Side Story. It's about a Romeo and Juliet story where Romeo comes from one street gang and Juliet comes from the other street gang, and it's a terrible story. It's a beautiful movie. You should watch it. Thank you. Thank you.
Thank you, Dr.
Thank you,
Newton.
sir.
Sorry. Thank you, Dr. Newton, for an excellent presentation. So all of this really is a culmination of all the oppositional defiance, which turns into antisocial behavior. So there isn't much time, so we will straight away move on to the next stop. Thank you, Vidhu.
Thank you, sir.
I think Dr. MKC sir, talk.
Kuna? Okay, good evening, all the dignitaries of AHA. Today had been a very bad day for me. Till 3 o'clock, I was doing research methodology workshop, and 4 o'clock I joined and sitting continuously, and this is not okay for my age and thing. That is a whole problem. Anyway, let's start with what is. We are not talking about child sexual abuse. We are going to talk about exploitation. Also, we are going to talk about how to recognize flags, red flags for this, and ensuring safety. There are three things I'm saying: child sexual abuse, exploitation, the red flag signs, and ensuring safety. Now, defines sexual abuse as a involvement of a child in sexual activity that child does not comprehend. 2, unable to give informed consent. 3, child is not developmentally prepared. And 4, hence cannot give consent, and it violates the rules of the land. Okay. So type of sexual abuse, there are plenty. These are basic information. Child sexual can happen in person or online. Abuser will gain a child trust first or control them through violence or blackmail before abusing. And this can happen in a short period of time. So when a child is sexually exploited online, they might be forced to send sexually explicit images of themselves, film or stream sexual activities, or have sexual conversations. The type of sexual abuse in another way is called acute sexual assault, penetrative abuse, vaginal or urethral discharge, STD in abuser, or positive pregnancy test in an adolescent girl. So these are the 4-5 situations a pediatrician is likely to. Either there's a history of acute sexual assault coming acutely to the casualty, or when you ask for detail, there is a penetrative sex happened, or when you look at the child, there is vaginal or urethral discharge, or there is evidence of STD in the abuser. Of course, we are not going to see the abuser at that moment. Positive pregnancy in the girl. Let's talk about physical abuse. The most important clue is injuries in the covered areas of the body, where particularly these children will come completely covered because they don't want to show anything outside. So if you have a injured area, covered area has injury, there's a patterned injuries reproducing shape of the impacting object. For example, hit with a club, then the pattern will be shown there. Injury that is inconsistent with the child's developmental capacities. You know the capabilities. That means this cannot happen by the child. Mechanism or appearance of injury changing over time or between caregivers. The protective factors for physical abuse will be empathetic, non-judgmental, and caring response of the healthcare provider, family support, stability and positive parental relationship, and living in communities with strong social cohesion, positive peer intimate partner affiliation. So 4 things. Number 1, there is a empathetic, non-judgmental, caring person. There is family support and stability, parental stability relations. And then you have living in a strong social cohesive community, and there is positive peer intimate partner affiliations. Universal campaign targeting child behavior abuse prevention. A systematic review was done, and most frequently targeted risk factors in the campaigns were lack of knowledge in positive parenting technique, parental impulsivity, stigma of asking for help, inadequate social support, inappropriate expectation for a child's development age. So as a parent, 3-4 things we need to do. 1, lack of knowledge on positive parenting technique has to be covered. Parental impulsivity, particularly in the male, has to be curbed. The stigma of asking for help, which is very much there in India, that has to be addressed. Inadequate social support has to be adequate. Red flags for physical abuse, the physical indicators will be difficulty in walk. If the child has been abused, there may be difficulty in walking or sitting, lack of bowel control, bloody discharge in premenstrual girls, anal bleeding in boys, venereal disease, complaints of pain, itching or swelling in the genital area. So a pediatrician has to look at all this if there is a possibility of abuse. Child's behavior also can be. Child discloses either, which is rare, discloses that child is sexually abused, bizarre or unusual sexual behavior. For example, I give you example. It was told a small child was brought, the judge was very kind, considerate, made him sit on the lap, and he started putting hands in the lingi. Because he thought the moment you put on the lap, he is supposed to do something else. So that is something very bizarre, unusual sexual behavior, out of proportion for his age. And having knowledge of sexual inappropriate for age. Excessive masturbation, lack of self-esteem, depression, and child talks of secrets that can be told. The secret is a cue that there is something going on. Parental behavior, there is a perceived child as different or bad. They never think of as a good child, they will say it's a bad child. Belittles or humiliates the child, insists that the child be treated differently, expresses or shows no affection towards the child. Because already they have branded him as a bad child, because all the fault is with the child, not with the abuser. So that is something with the parent, it has to be removed from the parent's mind. There's a beautiful study which says identification of red flag child sexual grooming behavior. Grooming means grooming the child towards abuse. That is a very important question. So they actually select, particularly pedophiles, they select victim selection. They have access and isolation. They have many methods of putting trust development, desensitize the child to sexual content and physical touch by showing movies and whatnot and all. Then they will give lot of caring in the post-abuse maintenance, so that child will not complain, and then say about secret deal and all that. So the endorsement of each behavior range between 8.2 to 72.2. That means charming, likable, nice. All that was very high. Involvement in youth service organization, 12 point. Now, red flag sexual grooming behaviors, especially those related to desensitizing the child to physical contact, sexual content, can be identified in case of sexual abuse and can have an important role in prevention. We need to understand that. Now, very often this can not related exactly abuse, but what we used to happen is we used to get a lot of teenage pregnancy, unmarried teenage pregnancy. So we did a large study on 362 unmarried teenage pregnancy, and what we found is the lack of appropriate parental control. Odds ratio was 9, which means 9 times more chance. If the parental control is not appropriate, either too loose or very stringent, then it's 9 times. Poor intra-family relationship, that means between parents, the relationship is not cordial, but not that they are separated, 7 times. If the child has lack of sexual reproductive knowledge, 5 times. And then of course, few other things. I think 975, this is what we need to remember. Poor parental control, poor intra-family relationship, and lack of sexual reproductive knowledge. Now coming to ensuring child safety in schools. I remember an incident in which something happened and all the big social people, leaders got together and they started blaming the teachers. The media suddenly called me, sir, come and say something, because here everything is going bad. So I said, The moment till the child enters the school, it's a responsibility of parent, because 3,000, 4,000 children in the school, teachers can't do. But there has to be a gate, there has to be identification card, and once they enter the school till they leave at 4 o'clock, it is a responsibility of school management and teachers. There you cannot shun your responsibility. So acting swiftly on the complaint of a single child, and that will be the model, that if you complain, action, and that's exactly what Newton was saying, even for ragging. If you complain, the child will be victimized. That cannot happen. School have a child protection policy in place. Installation of CCTV cameras in isolated areas, identification, close follow-up of drug abuse, regular parental awareness programs, and something called student support and guidance program, which I started in the university, Health Science University, for 324 colleges. Even now, 275 colleges it's going on. One male, female teacher is told about all this, taught about all this, sensitized about all this. Can't say taught, at least sensitized. And every month I used to go to the district, and the teachers come there and they discuss what are the problem along with a psychologist who is well versed in this one. We may have to do this, particularly it is possible in the private schools. In the government schools in Kerala, there are MSW student counselors. Now they are 10, 15 years old. They now know how to manage. Then screening all teachers and non-teaching staff for any problem-related behavior before they are appointed. Family, of course, you need to have family discord. How do you do it? Parental mental illness, parental substance abuse, single parenthood, poverty, and low parental education. How we can do, I don't know exactly. The school may not be able to do it, but if they can do as a part of their social responsibility, then that will be great. Because most often, such parents who have problem, mental illness, substance abuse, they won't come for any parent-teacher meeting. So from the other partner, you will be able to identify, and if the school has a program or college has a program, you can help him. In fact, there's a program called Inspire, 7 strategies for ending violence against children. It's called, first one is I is implementation and enforcement of laws. Because when it comes to child abuse and all, the question that every doctor asks is, how can we go by the law, letter and spirit? I know it is difficult. Even I find it so difficult. Because somebody has told you confidentiality will go, everything will go. But we have no choice but to do. Just now, morning, somebody was saying there was a problem. The pediatrician saw. After that, it was sent to gynecologist. But the gynecologist said, I am not the first person to, who saw it, so I don't have to report. The first person, by law, the first person who come in contact with such a child has to report to police. Here, most people get away by reporting to child line, something called child line, and hoping that they will report. But that's also one option. Norms and values keep changing. So I think we need to, societal norms and values keep changing. We need to be aware. We need to create safe environment, because our child is also studying there. So the Parent-Teacher Association have a huge responsibility to create safe environment. Parental and caregiver support, income and economic strengthening, which of course we can't do it. Response service provision. If there is a problem, it will be responded to. You have to have a network of people, not only teachers, then you have to have a psychiatrist or somebody available. Education in life skill, which everybody has told about. Now, for pediatrician, particularly when a child come, even before all this came, I'm talking about 40 years ago, if a child came to casualty with so-called any symptom of or signs of abuse, I will send, particularly if it's a girl, I will send with a PG, lady PG to the gynecology. And she will say, sir, you are alone in the casualty. How will you manage? I said, don't care about it. The reason is already we have talked nicely to the child. The child has got an affinity for you. Now, if they are sent to a gynecology where they are so busy and they may not be very child friendly, then the child is in huge trauma. Whereas somebody accompanies her and go and show for physical examination, she may be much more comfortable. That's the whole story. If you have unexplained genital injury, that you have to see, of course, after asking for permission and all. You don't have to do the detailed examination that gynecologists will do. But of course, you have to know whether there is a problem, recurrent vulvovaginitis or penile discharge, bedwetting and fecal soiling beyond the usual age. That means he had stopped all this, suddenly it has started again. That means there is some problem. Anal complaints, fissure, pain, bleeding, etc. It may not be by this alone, but if you have, just think of the possibility of abuse. Pain on urination, UTI, STI. If STI means 100%, you have to think about. Presence of sperm or pregnancy. Acute, of course, you may have presence of sperm or semen. Behavior indications for pediatrician. If the child shows regression behavior, regression in school performance, and difficulty in attaining he was developing okay till last 6 months ago. Now suddenly everything has gone back. Pediatrician must think in the back of the mind about a possible abuse, exploitation, or neglect. Clingy behavior, irritability in very young children. They won't leave the mother. Clingy. Sleep disturbance, eating disorders. Problems at school or social problems. That is very important. Child may show depression or poor self-esteem. Inappropriate sexual behavior. So any of this list is there, the pediatrician, the red flag, you should think of that. Now, what is, when you do look at the Indian government of India's also report of, child abuse, it has gone into 80%, 70%, 80%, very high. I personally don't believe, it's all exaggerated. Very little small thing which has not affected the child also will be taken as. If we keep on probing the child, did something happen, then he may say, yes, something had happened that time. No, not that. We have done a very serious study, UNFPA supported study on 3 districts on young adults between 10 and 24 young people, 10 and 24, 3 districts, a sample of 4,225, and we had clear-cut message of 10% girls abuse and 5% boys. But then there is another issue there we looked at. The parent-adolescent dyad agreement. There was positive out there. I'm only talking about negative. Parents taken precaution to prevent sexual abuse, only 17.5%. Only 17.5%. They all wanted us to talk about HIV/AIDS and all, but they didn't want us to talk about anything else. Have been sexually abused, only 15% has been realized. I'm not talking about number. Whatever be the number, 15% only parents have any clue that child was sexually abused. So the last, of course, slide is, what is the Indian perspective? We can take, in psychology, we say, you can take the affect model, feeling model, the reaction, emotional pathway you can take. You can take a cognitive pathway, thinking pathway. You can take a practical pathway. I believe in doing a cognitive and practical pathway rather than this one. In that case, what we need to address is, teach the adolescent, not good touch, bad touch alone. You tell the adolescent that your life is, your mind, body, and spirit is your alone. You are the custodian of your mind, body, and spirit, and you have to protect it, preserve it, and enhance it. In fact, wherever I do an adolescent program, now of course I do a young adults program, I take them an oath that you are the custodian. Somebody can't run over you. Nobody can touch you. What can be done? And more than the good touch, bad touch, your private parts cannot be touched by anybody else except maybe your parents and the doctor, that too in presence of the nurse or the mother. That need to be taught from very beginning to the child. Nobody else can touch your private part. and every child understand. If it is small child, only below private part. If it's a plus 12 plus girl, above also become private part. Then the parents have to be told about what are the possibilities. They don't know all this. So you need to teach them in the school parent meeting, and teachers have to be taught about it. And the way to teach the teachers is, if you teach them to tell about their children, they won't listen to you. The way to do it is you talk about their children. Or teachers can be converted only by talking to them about their children privately. If they had a problem and give solution to that, then they will be doing it. And religious heads, of course, can play a huge role, because particularly in church and all, every Sunday they are talking. They can talk about it. When a priest talk about it, it has respectability. And law, police, judge, all this come only after that. So this triangle, I think we need to remember. Instead of saying, because the reason why I'm saying it is, if 1,000 cases are reported, not even 1 or 2 get actually punished. So punishment is not a way that in India it works. Somehow they can get out of it. So that is one way. The teachers or the non-staff in the school has to be, their police record has to be collected early before appointing them. That's the most important part. So that is in sum total, whether it is sexual abuse, exploitation, or looking at the red flags, or talking about safety, it becomes a responsibility of a pediatrician attached to that school. And IAP had decided that we will have one pediatrician attached to every school. You are not taking responsibility for legal responsibility, everything, but you are a facilitator for parent-teacher initiatives, and you can be the patron for that. Thank you very much.
Thank you very much for the excellent talk. But Dr. Deepa, are you there? Any questions we can take, or you have to move on to the next session?
Ma'am, questions will take, they can put in chat box if there are questions, ma'am. Let's move on as we are late.
Already it's late.
Yes,
Yeah.
yes.
Okay.
Thank you, madam.
Okay. Thank you, sir.
Yeah.
Ma'am, let me take this out. What is it?
Thank you, MKC. Lovely talk.
Maybe I think everyone can share. They can post in the chat box. I think.
Thank you, sir. Now we shall move on to our final session. It is on helping children and teens grow up healthy, smart, and kind in a screen-saturated world. To chair the session, I invite Dr. Sushma Desai. Madam is chairperson-elect for our AHA. Ma'am is director of Gobi Children's Hospital, and she's also the founder, chairperson of AHA Gujarat. Over to you, ma'am.
Thank you, Dr. Vidhu. A very good evening to all. And it's always a pleasure being with AHA Kerala team. First of all, I would like to extend my heartfelt congratulations to Team AHA Kerala under the leadership of dear Dr. Deepa, Dr. IP Kerala, as well as IP Kochi to organize such a wonderful webinar. It has been a very enriching learning experience throughout, to be cherished for the days to come. We have come to the fag end of this webinar with another excellent topic to be delivered by a super excellent speaker, Dr. Michael Rich. Dr. Rich is an assistant professor of pediatrics at Harvard Medical School, and he's practicing adolescent medicine at Boston Children's Hospital. To some extent, he is very popularly known as mediatrician. That speaks volume about his expertise regarding this topic. I guess to some extent, this expertise has its roots in the fact that it's interesting to know this thing, that he has chosen his first career as a Hollywood filmmaker. I think that has, provided him with a unique understanding of the power of screen to engage, contact, and change our lives. He founded the Digital Wellness Lab and the Clinic for Interactive Media and Internet Disorders at Boston Children's Hospital. This helped bringing together the researchers, clinicians, and tech leaders to research the positive and negative effects of media and technology on children's health and well-being. He had facilitated to use this research to respond to and innovate a digital environment in which we can raise healthy, smart, and kind kids. Friends, it's very, very difficult, I think, next to impossible to deprive our teens of, totally deprive of them from the integral part of their life, that is media. So it's always good to empower them to live in harmony with this integral part of their world and helping them, to grow up healthy, smart, and kind in a screen-saturated world. We welcome you, Dr. Michael. It's an honor to have you with us. Thank you, sir, for being with us.
Thank you for having me. I'm hopeful you can hear me all right. Everything's good? Okay, perfect.
Yes, sir.
Well, I will jump over to my slides and we'll get started. Okay, share screen. Okay. All right. Well, thank you for having me to speak today about helping our kids grow up healthy, smart, and kind. As you mentioned quite potently, these kids live in a very screen-saturated world. And what we've all seen, the headlines and the fear, but let's talk about what we're really doing in response to this. Unfortunately, we're
Dr.
seeing
Rich,
a
can
lot
you
of
please
moral
make
panic.
it full screen? Can you please make it full
Oh, I'm sorry.
screen? Yeah, we can't just...
Well, hang on a second. I will back it up then. Why is it not full screen? It's full screen for me. Hang on just a moment. I will step back. Okay, let's see here. New slide. Is that better?
That's better.
Yeah,
yes,
that's
yes.
better.
That's good.
Yeah.
Okay, you have it now. Okay. Sorry. All right. I guess the theme of today is technical glitches. So I apologize for contributing to that. So to start again, as pediatricians, we are all privileged and honored, but also obligated to really oversee the healthy growth and development of children who are growing up in a very different world than we and their parents did. We've all seen the fearful headlines that Facebook is harming girls' body image, that kids are addicted to screens. And we've seen the moral panic around this, that somehow we have lost a generation to smartphones and social media. And the reality is that 90% of infants now are given screen devices before the age of 1. I will say that most of these data I present are US data and probably are different, but probably not so very different in India. Most 2-year-olds are using a mobile device daily. When we ask parents why, 70% say it's how they get chores done. 65% say it calms the child, which most of us realize is actually not true. And 29% use screens to put the child to sleep, staring into the blue melatonin suppressing light of a screen. 73% of parents use devices while eating, which means that many of the kids are doing exactly the same thing. And parents who have devices in the playground are distracted 30% of the time, and during which time kids are 2 to 3 times more likely to take physical risks. So what we have to really understand and accept is this is what we're calling the next normal, not the new normal, because today's new normal is tomorrow's old normal. This ecosystem is evolving so rapidly that we need to be looking not only at what's happening now, but what's around the corner, what's going to happen next. Kids are growing up in a screen-saturated world. It's in virtually every built environment now. They're in their pockets. They're on many of their wrists. And teens are actively using screens for 8.5 hours every day, and in many cases are multitasking with 2 or more screens, resulting in a cumulative exposure of 11 hours and 45 minutes on average to media content. 17% said that they increased during the COVID pandemic, which was surprising to everyone because they said, oh my God, it went up dramatically. However, what they really discovered is that kids were already using screens a great deal, even before the lockdown, and they were on screens for school as well. Interestingly, though, what did increase dramatically was the level of arguments and the severity, both severity and frequency of arguments between parents and kids about their screen time. So instead of thinking of this as screen time and non-screen time, we have to really understand that young people are now engaged in a constant, often simultaneous interactions in both the digital and physical worlds. They move seamlessly back and forth between them. And in fact, we have found that the concept of screen time is obsolete in the sense that we don't use screens the way we used to when television was the only screen in our lives. We move seamlessly back and forth between them all the time. And so screen time limits, which frankly never really worked, even in the days of television, are not a good way of managing screens for kids today. We will talk about how so 54% of these kids say it would be really hard to give up their social media. And 84% check their screens every hour. What was more shocking to us actually was that 16%, 1 in 6 kids say they check their screens more frequently than every 5 minutes. This includes during the school day. So it's a constant distraction, a constant pull of their attention. But we're also in this rapidly evolving digital ecosystem that allows young people to be connected to anyone, anywhere in the world at any time. Look at what we're doing right now. We are having a webinar around the world simultaneously. This was never possible before. This is an amazing opportunity for all of us. And yet many of us are caught up in the dread FOMO, or fear of missing out. But for young people, what is perhaps even more potent than FOMO is what we're calling faux blow, fear of being left out, fear that if they don't respond to a text or a social media post instantly, that people will construe that they don't love them anymore, that the relationship isn't as good as it was. And so they hesitate to look away from those devices in case people would think they're ignoring them. But ironically, in gaining this near infinite connectivity that we have, we've actually eroded away and lost much of our deep and meaningful and protective connectedness with each other that really occurs in being face-to-face, in person, really with each other in real time and real space, able to respond to their body language, to their faces, and to their silences in their conversation. One of the huge debates right now in the US, at least, is smartphones in schools. Essentially 100% of kids now have smartphones, and many of them have them in schools, and schools are really struggling with how to manage this. An interesting experiment was done by a teacher of 12 and 13-year-olds, middle school in the US. And what she did is she said, I want everybody to take their phones out of their backpacks and put them on their desk. Turn on their ringers as loud as possible. And each time you get a notification, I want you to put a mark on this big poster in the front of the classroom. So in one 45-minute period with a 20-person class, they got more than 1,100 pings, 1,100 signals from Facebook, Snapchat, email, text messages, phone calls. And we have to really think about what role these very powerful tools have in school. Let's think about what role school has in the life of a young person. The first, of course, is their didactic learning of course content in math, in science, in literature, all of the things that we go to school for. But for all of us as pediatricians, arguably, the even more important learning that occurs in school is the social emotional learning, the learning that they will use throughout their lives of how to interact with other people, how to take on challenges, how to deal with failure. This is the first opportunity they have to be individuals in a society of their own making. And this is where they work these things out. If they're in class and they're interrupted and distracted more than 1,100 times, the didactic learning does not occur well because they're constantly pulled away from it. Social emotional learning gets even more complicated because they are never alone. Their parent can ask them, how did they do on that quiz? Do I need to talk to your teacher? What's going on in the playground? And they never have the opportunity to work these things out for themselves. This is helicopter parenting on steroids, if you will. And this is arguably the most important learning that occurs in school is how do I function as a human being in society?
Hello. Good evening, Anisha. वो सलमा को
Sorry? Oh, okay. That was okay. That was just someone who was not muted. Okay. So let's talk about why young people are so attracted to these devices and these applications. It's because the interactive media we have today, not just receptive media like television, but the interactivity provides a really fertile environment for key tasks of adolescent and child development. The first is they seek experience, and they can get experience in a much larger arena than they used to when they were restricted to their physical environments. They seek both real experience with people and experiences around the world, but also vicarious experiences through games, etc. They seek independence from parents, from teachers, from authority figures, and these tools allow them to function as an individual in a large world. They become socially conscious, look beyond their nuclear families to a larger world, and they're worried about things like climate change and politics of various kinds. And this environment allows them to find people who feel similarly around these issues. They are building their identities, which used to happen from the experiences we had with those closest to us. Now they're building their identities on influencers and celebrities and movie stars. And finally, with these new identities that they put together for themselves, they seek connection with each other. Even though the kids are not on Facebook, Facebook is now the largest nation on earth with over 3 billion people using it every month. So let's think about what's going on in the adolescent brain. Well, as we all know, the brain develops back to front. What's in the back? The visual cortex. What's in the front? The prefrontal cortex. Impulse control, future thinking, judgment, all of those things that we really won't develop fully until we are mid to late 20s. So they're visually sophisticated, so they're able to really pay good attention to the visuals on these screens. It's just their judgment of what they do with that information that sometimes is lacking and sometimes they're struggling with. So many people said the pandemic caused this problem, or the pandemic is really to blame for these kids being on screen so much. But what we found is that they were already on screens a great deal. But what the pandemic did is it accelerated their use of interactive media because they were dependent on it for schooling, for virtually every activity of life for a period of time. And because they were enclosed in their homes or however their lockdown situation was, it amplified the effects on their health and development, since this was their only sort of connection to the world. What causes the excessive use of media? Our clinical experience from the Clinic for Interactive Media and Internet Disorders and our research at the Digital Wellness Lab have shown actually that it is not a specific device like a smartphone or a specific activity that is problematic, like social media. It's the interactivity that engages and immerses the user so they lose track of time and place. There is nothing a young person likes better than having someone pay attention to them, having someone respond to them, having someone to interact with. It is that interactivity, even with AI chatbots, that draws them in, even with a game that draws them in. And so the algorithms of social media and games are such that they keep grabbing them and pulling them into these environments. What are we seeing in our clinic? We are seeing really 4 major areas that kids get in trouble with online. The first is video gaming, excessive gaming on computers or consoles or mobile devices, more prevalent in boys. Social media issues, somewhat more prevalent in girls, although boys are catching up. Pornography, unfortunately, this is not one that they talk about because of the stigma attached to it, but many young people are having their first exposure to sexual behavior being in pornography rather than in sex education in responsible ways. And what we're calling information binging, which is the endless YouTube videos or Reddit or Quora ways to go down various rabbit holes of information. And what we're finding in terms of the behaviors coming to us, we're calling it problematic interactive media use. This is something that has been worried about and thought about since the 1990s. It was originally thought to be an addictive disorder, but our findings are somewhat different from that. But what we're seeing is they're coming in, perhaps the greatest hit on their health and development is sleep, but nutrition in both directions, both overweight and obesity, because they're sitting in front of a screen and snacking, but also body image disorders and eating disorders occurring from the social media upward social comparison. It affects their social life. They become more interested in what's happening online than with their peers, their families, etc. And it affects their mental health when they are immersed in a screen and more detached from the physical realities of their lives. So the Clinic for Interactive Media and Internet Disorders has been in operation since 2017, and we've seen hundreds of kids, and we'll share with you some of our findings. This is the research that we've started and hope to go worldwide. We've been talking with Dr. Preeti Galagali, who I see is online. Hi, Preeti. About doing this with a research site in each of the 6 populated continents, but to really look over time at the exposure young people have to screens and a host of health and developmental outcomes. But this was baseline study from Canada, our first site of the Growing Up Digital or GOOD study, where we asked parents and grandparents if they felt their children were addicted to technologies. Interestingly, the parents came back and said, well, actually, 30% of us feel that we're addicted, and only 22% felt their kids were addicted. When we asked the grandparents, of course, they said, oh, they're both addicted. So, but let's talk about what is addiction? First of all, as we all know, as physicians, this is not a medical term at all. It's a social term, right? That we talk about substance use disorders. But what is addiction as a social construct? It is overuse of a pleasurable but unnecessary substance, whether it be alcohol or cocaine or opioids. It is driven by physiologic needs to feel good and then not to feel bad when they withdraw. It is continued use despite negative consequences in their lives to relationships, to health, etc. And our therapeutic goal with it is abstinence or, very much reduced controlled use, harm reduction. Let's think about what's happening with these screens. This is overuse of what is now a necessary resource. These kids need to have access and ability to use these screens to learn, to communicate, to connect, to entertain themselves, basically to do everything in their lives. And the overuse is actually driven not by physiologic but psychological distress of one kind or another. And they are seeking to soothe themselves in this environment. They're seeking not to be left out with that phoblo we spoke about. It does have continued use despite negative consequences, but our therapeutic goal is not abstinence because they cannot do abstinence, but self-regulation. So we see this as actually more akin to binge eating disorder, the most common eating disorder, which similarly is overuse of a necessary resource, food, driven by psychological needs, continued use despite negative consequences, and our therapeutic goal is self-regulation. So what are the psychological conditions that predispose to PIMU, to problematic interactive media use? In virtually every case we've seen, in the hundreds of kids we've seen in SimAid, it is one or more of 4 underlying psychological drivers of these behaviors. The first is attention deficit hyperactivity disorder. These kids who struggle in school do really, really well with video games, for example, because that distractibility actually is a relative strength. Social anxiety drives them to social media, drives them to connect with others in what feels like a safer, less intimate environment online. Autism spectrum disorder. Kids on the autism spectrum who struggle to read expressions, to read people's emotions, do much, much better in this environment and often will disappear into it in favor of it rather than be with others. And finally, depression. Now, certainly anxiety and depression are not just precursors, but are exacerbated by these uses. So one of the things that we use to remind our students is look for a SAD patient who's having trouble with it, which is the ADHD, social anxiety, ASD, and depression. So how do we deal with this? We talk about the 5 M's of digital wellness. As pediatricians, we are much more interested in preventing problems than we are in solving them after the fact. We're very good at intervening after the fact, but what is better is to have them never happen. So these are 3 things that we can do and 2 benefits we get from them. The first M of digital wellness is for parents and all of us to model the behavior that we want to see in the kids. If we are staring at our smartphone at the all-important email while yelling at our kids to turn off the video game, to them that's the height of hypocrisy. That doesn't make sense. We have to be the change we want to see. The second is to mentor them in the use of these devices, these applications, etc. The reason I use the word mentor rather than teach is that parents have said to me time and again that they dread the internet talk more than they dread the sex talk because they think they know something about sex and they're sure their kids know more than they do about the internet. They want to be the expert. But when a mentor meets with a mentee, they both learn from each other. And so a mentor is allowed to come to this experience of figuring out a smartphone or figure out social media with curiosity rather than fear or judgment or superiority, like they're an authority on it, and they can learn it together. And one of the nice things that happens there is you start a dialogue with your child, not blaming and shaming or fearing or feeling guilty, but one of seeking to constantly understand what's going on in the digital space for them and for us all. And that leads into the third M, which is to be able to monitor your child's use of the digital space. Now, both parents and kids push back the hardest against this, simply because the parents say, I don't have the time to be on video games with him or her all the time or be on social media. And I say, you don't have to be, you just have to be able to be. What this means is the child knows you are there behind them, not to spy on them, not to, pry into their secrets, but to be there as a support for them if they get to some place that they won't understand or that upsets them, etc. It allows them to be able to come to you to sort out the scary, confusing, upsetting spaces they will get to, because it's inevitable that they will. They're a click away. So being able to monitor them not only gives them a sense of you being behind them, but it also changes their behavior, much the way that random drug testing in the workplace changes the behavior of the worker. That they know that someone's back there, they will behave differently. And one of the things I actually tell kids, in terms of their own use, in terms of what they post online, what they put up there, is not to post anything they don't want their grandmother to see, because her grandmother can see it. And while kids don't mind making their parents angry, they really want the unconditional love and respect of grandma. And so I think I think that's a good rule for them, and it often is a better check than saying your parents will be mad at you. Now, if we can observe these three effectively going forward, we are preserving two really wonderful things about living and growing up in this environment. And the first is making memories. We don't make memories of the video games we play. We don't make memories of the back and forth on social media. We make memories of dance parties. We make memories of taking a walk with our grandparents. We make memories of trying to cook something and spilling it all over the kitchen floor. It's our interpersonal human interactions that we build memories on. And finally, if we are able to do these three, we are helping our children not to be safe in this environment, but to be masterful in this environment, to use these powerful tools to help them become smarter, kinder, and healthier humans. So the 5 M's, as we just reviewed them, are model, mentor, and monitor in order to make memories and establish mastery. I want to offer to you all the resources of the Digital Wellness Lab at Boston Children's Hospital and Harvard Med School, where we seek to understand the effects of the media we use and kids use and how they use them, and use them to empower wellness rather than encounter harm. To seek digital wellness as an intentional state of physical, mental, and social health that occurs with mindful engagement in the digital and natural environment. I use the word environment in the singular because they live in one single environment that is both digital and physical all the time. So what are our recommendations to parents? Use media with your kids. Instead of yelling at them to stop playing that violent video game, yes, I'm going to encourage you to sit down next to them and play that game with them. This is when parents turn pale, but it is an expression of love for that child, of respect for the child, seeking what engages them there. Learn from them what engages them and teach them the executive functions that they are a decade or more away from developing of impulse control and future thinking. But be there with them to model that. Treat these powerful devices as the powerful tools they are, not as treats to be given for good grades or taken away for bad behavior, but as tools with which they're going to be pursuing their lives, much the way we teach them to drive an automobile, right? This is something that gives them great freedom, great possibilities, but also can create harm for themselves and others if used inappropriately or ineffectively. Help them to develop critical thinking, not to just buy everything that they see online, but constantly to check it against their life experience, constantly to be injecting cognitive dissonance and saying, is this really true? Are there other alternatives? Also, how are other people, other genders, other races, other religions or ethnicities going to respond to this material? And is this really a full picture of life? Help them to prioritize and manage their 24-hour day. The days where we could have 2-hour screen time limits are long, long gone because we can't even measure screen time. So we urge them to turn that paradigm upside down and think of the 24-hour day as an empty glass that they fill up with 8 hours or more of sleep. Sit-down family meal without devices every day. The single most protective thing we can do, not just for their nutrition, but for their mental health. Time for homework, time for strenuous physical play. And let's see how they do. See how they live their lives and adjust it for them to be full and rich and diverse human beings, as opposed to using the screen as a default behavior. And finally, teach them actively to create online. They are creating all the time anyway. They are creating every time they post a Snapchat, every time they write something online, every time they text someone, they are creating, and they are creating a digital footprint that will be there forever for all intents and purposes, and they will need to answer for when they want to get into a college or get a job. So we need to help them be active creators, but conscious creators of their digital footprints. So finally, instead of seeking killer apps, which people were all for in the big tech boom, let's develop our killer bees. There are 4 killer bees. Be mindful in our use of screens and in our intentional non-use of them, putting them down and being together, taking a walk, talking to each other. Be balanced in our screen and non-screen use. And really controversially, perhaps, I think we need to be bored. We have to bring back boredom, because boredom, which we are now so averse to that we can't get on an elevator without looking at our smartphone, is the crucible of creativity and imagination and innovation. Instead of turning our minds over to someone else, let's open up our imagination, which not only gives us the mind space for imagination, but boredom is a little uncomfortable, so we seek to fill that mind space. Nature abhors a vacuum, so we fill it with thinking the new. And perhaps most importantly, for parents especially, is to be present. I ask my teenage patients when their parents are out of the room, what could your parent do better? Almost always the first thing out of their mouth is pay more attention to me. These parents think their kids don't care, their kids aren't talking, their kids aren't sharing their lives. They do want to be paid attention to. And if we're staring at our smartphones, we're not there, we're not present for them. So I want to offer to you the Mediatrician's Guide, just came out. This is a compilation of 30 plus years of both research and clinical work in this area. and also the resources online of the Digital Wellness Lab, where there's a lot of research, there's a lot of possibility, and I would especially urge you to reach out if you want to join Dr. Galagali and me in the Growing Up Digital India project. So thank you for listening, and I'm not sure whether I have an ability to take questions or not, but I will do so now.
Thank you so much for an excellent talk, sir. We learned 5 M's of digital wellness. That's modeling the behavior, mentoring them in judicial use of media use, monitoring their use, creating memories with the children, and of course, to be helping them to be masterful of this digital environment. And we have learned the recommendations for using media with the youth, and devices are the we have learned this dictum that devices are the tools and not the tricks. Of course, we will remember your bees, killer bees, and we will try to enforce those things. Thank you so much. It was a wonderful talk, sir. Thank you.
Great. Thank you.
Dr. Rich. Thank you, Dr.
Dr.
Rich. It was
Michael,
great.
I've heard you so many times, but every time it's a new learning experience. You're really wonderful.
Well, keep coming back, Swati.
Always.
It's good to see you and all my friends there.
Thank you.
Thank you, Dr. Rich. It was lovely talk. But what about your recommendations for screen time below 3 years of age? Did you say that? Did you say something about that?
Absolutely. No, I mean, this goes back to the beginning piece of model the behavior and mentor them. We shouldn't be handing these devices to very young children just to calm them down, right? We shouldn't be treating them like the electronic babysitter or as a pacifier. But we should recognize that they can do certain things very well, but they don't do everything very well. So with kids under 3, I think you use tablets very sparingly and in very educational situations with an adult present. I don't think handing them the device and just walking away is useful. It doesn't move them forward in any way. Just as we wouldn't necessarily hand them a book and say, have at it and read. Let's understand, though, that these devices, while being incredibly powerful teaching tools, need to have the relational intervention and interpretation of an adult. And I honestly don't see a positive use for a screen other than with co-viewing with an adult for very young children, and then perhaps putting them, teaching them to interpret what they are seeing. So a lot of times people say, when should I start teaching media literacy to kids? And I say it's the moment they start using media, right? So we're doing that when we read a board book with an infant. We are showing them that humans communicate by printed matter, by pictures, and we point at the cow and we say moo. And we should be doing exactly the same thing with these powerful devices and not handing them off as if they are a substitute parent.
No, because it can delay language development, isn't it? Language development will delay language development because below 3, autistic children, you give them, they become autistic.
Absolutely.
They depend on the inanimate objects and they don't feel the need to communicate with humans.
Exactly. Exactly right. And you know, I think that we need to look at these devices for how they can actually support young people on the autism spectrum and help them to be able to interpret, you know, the way other people communicate, not just with words, not just verbally, but also in their facial expressions and their body language. And there actually are very good uses for that. And then helping them transfer those skills to the physical world.
Dr. Rich, your thoughts about the AI in adolescence?
Oh, how much time do you have?
I call you for another talk, I think.
I mean, here's the issue. And actually, The last part of my book is all about basically about how can we build on our learning from media we've experienced to date to project forward into the world of AI. And the real issue with AI now, first of all, unfortunately, the very first ventures into AI with education were not to use it as the powerful research tool it is, but to defend against it as a plagiarism tool or as a cheating tool. And it's actually, something that we should be actively teaching young people about and teaching about how to handle it responsibly, because kids are already using AI not just to cheat, but actually to harm each other. We have, early teens who are taking their classmates' school photos and making pornography with them. So these are, we need to be leaning into this and helping them learn to use it well, and not to either cheat with it or use it to harm others. And I think that we often are 2 steps behind the kids. And this is why we have to do the mentorship. We have to be right there with them and learning with them. Because yes, they will be more adept at some parts of this than we are. But as long as we're in a dialogue with them as mentors and mentees, but also into the monitoring phase, we can, venture into this brave new world together. Will we do it perfectly? Of course not. But we have to keep trying. This is and always will be a work in progress.
Dr.
Thank
Rich,
you so much.
it was a wonderful session. Yeah, I had one query. How do you help them deal with fear of being left out?
Oh, that's what I usually say the most important thing is when they are interacting with a friend or someone they hope is a friend, they should always try to upgrade by 1. Okay. What I mean by that is, oftentimes people go at these media devices and applications in terms of how to restrict them. But I teach them to value what they're doing. So instead of tweeting, text. Instead of texting, call. Better yet, video call so you can actually see the person. But best of all, get together in person. Always think about how to get together one step further. We have gotten into a bad habit because of our fear of being awkward or feeling weird or being noticed that, someone will see that pimple on our forehead or whatever, that we will, be put down. But, I teach the kids, this is, we shouldn't fear being connected with people. We shouldn't fear intimacy with people. And, with the teenagers, I'll even say, you can reach out with a smartphone, but you can't make out with a smartphone, and that gets their attention.
That's great. Now, what about feeding children? When you're feeding children, you give the mobile. When you're feeding children, when you're small babies, you give the mobile to feed.
Absolutely not. I don't think any of us should have a mobile or a screen of any kind at the dinner table. Not only does it, distract us from the eating itself, the nutrition, because we've got to learn to eat and we've got to learn to eat a balanced diet. But more importantly, even, it distracts us from each other. Breaking bread together, having a meal together is so much more than just nourishing the body. It's nourishing the mind and the soul as well. And it's when we connect with each other. And, it's a terrible habit that people have gotten into in the US at least, where they walk into a restaurant and they hand out mobiles or tablets to their children, instead of having a conversation with them, instead of helping them learn to wait for their meal and to fill the time. I think that we've gotten lazy, if you will, in terms of our interactions with each other. That's not even approaching what kind of content they might be on during that time. This is lost time. Our time with them is fleeting, right? They grow up so fast. Why would we want to waste it by having them stare at a screen or play Angry Birds?
I must also say here, we thank Dr. Michael Rich for contributing to the IAP guidelines on digital use and media. And I think, Dr. Uni, all this has been addressed in that, especially for the younger children. And we have strongly said that, we avoid the use of screens less than 2 years, especially. So thank you very much, Dr. Rich, for being a part of IAP.
Thank you. Yeah.
Well, thank you for welcoming me, and thank you for working with me, and I look forward to the future working together.
We look forward to, sir.
Yes.
IAP also look forward.
Vitu?
I'm sorry, I didn't catch that.
Sir, they were
She
saying
said
IAP is looking
Adolescent
forward
Health
to work with you.
Academy. Looking forward to that. Adolescent Health Academy is a subchapter of IP, and that
Yes.
chapter is looking forward to having you there. Yeah.
Oh,
Thank you,
excellent, excellent, excellent. And I would welcome you all to the International Association for Adolescent Health as well. Dr. Galagali can tell you all about it. And we're meeting in November in Jamaica.
Yes, that's what I also want to invite everybody for. Welcome to Jamaica.
I'm sorry, I stole your line, Preeti.
Academy, sir, we all thank you. So we thank you on behalf of Adolescent Health Academy and IAP, Indian Academy of Pediatrics.
Thank you.
Thank you.
Thank you for having me and welcoming me. All right.
Thank you, sir.
Be well. Yes.
Now we welcome Dr. Riaz, President IAP Kerala. Sir couldn't attend the initial session. Sir, would you please join us, sir?
Yeah. Thanks, Dr. Deepa, for the kind invitation. So I'm right now I'm not in a very good network area. That is why I'm not opening the whole video. Thank you for that. But I was able to listen to most of the deliberations, and it was really nice to listen to Dr. Michael. And actually, I think we have created a very good archive for revision. So this need to be uploaded in, we will upload in IAP Kerala website, and this can be uploaded in the central website also, so that it will be helpful for not only for adolescents, but not only for pediatricians, but also for parents, because the information which has been deliberated here is so simple, and it can be taken up for training. I think we can train school counselors, we can train teachers with this matter which we have discussed here. So I offer all the best to the IAP Adolescent Chapter, and I should congratulate Dr. Deepa, Dr. Vidu, the whole team, and we have our MK Sisar as our real mentor, and Geeta Madam, and all the torchbearers of adolescent health. And I think this work will continue, and we will all make our adolescent chapter the best one among the subchapters of IAP in our country. So all the best for your future endeavors, and thank you for the opportunity. Thank you.
Thank you, sir. Any doubts or any comments?
I just wanted to apologize everyone for the delay, but the talks were too good that we didn't feel like interrupting. Sorry for the delay. And big thanks from the bottom of our heart for all the faculties, all the participants, all the chairpersons, everybody for being here with us even at this late hour. Thank you all.
Thank you, Dr. Deepa. It was excellent, very wonderful webinar. And keep going. And we look forward to having more and more such webinars from AHA Kerala. Thank you.
Thank you.
Thank you, Deepa.
Thank you, Dr. Deepa.
I
also want to thank all of you, AHA Kerala, AHA, I think IAP Kerala, all of you. That's excellent. On a Sunday, long sessions, but they were so good that I think many of us they stayed on. And to add the international flavor, we had Dr. Rich. That was so rich actually. The CMA itself was very huge, rich in the content and a lot of messages. I hope these sessions will continue. Congratulations, kudos to you, Dr. Deepa, AHA Kerala. Kudos to you. Thank you.
Thank you, ma'am.
Thank you, Dr. Deepa, for giving such a great sessions for us.
Thank you, ma'am. Jason sir, can we call it a day?
Yeah.
Yeah. Thank you. Thank you, sir. Dr. Jason, sir, thank you for leading from the front.
All the talks were so wonderful. Preeti, Swati madam, everybody. Jason sir, thank you so much
Thank you very much, sir.
Organize this program. Thank you.
Thank you so much.
Thank you. Good
Thank
night.
you,
Bye-bye.
sirs and
Good
madams.
night.
Everybody,
Bye.
good night.
Good night.
Have a good night. Thank you.